started, I want to let you guys that are in the audience look up and see the white microphones. I've been told that they pick up everything in the room, so if y'all are having even quiet conversations, it will pick it up and put it out on the loud stream, so be careful. All right, Senator Jackson.
Well, let us pray. Holy and loving God, we give you thanks for the beauty of this day. We give you thanks for our hosts, for the students who are gathered here to learn and to study so that they might bring healing and health to Georgians and people across this nation and world. We ask that you would bless each of us, that you would guide us, that you would give us wisdom. We might be able to make decisions so that everyone can receive the care they need. Amen.
All right, so we're gonna get right to it. My goal is to have us out of here by 3 o'clock. So, Jet, Tony. Yes, sir.
Thank you, Mr. Chairman and members of the committee and staff. Jen Tony, Executive Director of the Georgia Society of Anesthesiologists. You have before you a very dense list of recommendations. And some of you might say, well, that's perfectly appropriate for you, Jeff, to do something dense. But I'm going to ask you to turn to the last page of that, and you will note at the bottom of the last page addresses for and contact information for me and Dr. Amanda Brown. Dr. Brown is the Government Affairs Chair of the GSA, and she is responsible for much of the research and consideration of these extensive recommendations. She has been hit by a bug and did not have a pleasant day yesterday and will not be here today. So I am doing my best to fill for her. So the GSA is an organization that is comprised of physicians, resident physicians, certified anesthesiologists, assistant medical students, and student AAs. Members of the GSA advocate for physician-led medical care so that every patient, regardless of setting, benefits from a team approach where the skills, training, and education of multiple practitioners are invested in patient care. GSA, the Medical Association of Georgia, and many other medical specialty societies throughout the state are committed to ensuring that patients have access to safe, high-quality, physician-led medical care. However, Georgia, like many states, faces ongoing challenges ensuring access to medical care services for their citizens living in rural and underserved areas. Now, I hope our committee members will understand that when we refer to rural areas, we consider our recommendations to be also applicable to underserved areas in urban areas. So patients in both of these settings deserve access to the same level of health care as patients in urban and suburban settings. So when we speak of physician-led health care, we are talking about a team approach, which allows trained healthcare professionals working together to invest their several skills and various training to work for patients. Now, these recommendations, I will not even attempt to go into all of them, but they have come from various sources, and I hope that you will especially take note of what other states are doing to incent the production of healthcare professionals at all levels. So what I'd like to do to start is just hit some high spots. Clearly, the state, you and the legislature need to do some things. And what we have put together here, you'll have to read it later, and staff will have to read it. to really drill down to all of it. But I'm not going to mince words because we don't have a lot of time. Things are not improving in the rural areas as fast as we want, nor as fast as citizens and taxpayers in those areas deserve. So what I will say to you today, and what you will read, is there's basically two pathways for you as legislators to do your part to help improve conditions for rural and unserved areas. One are the things that you can do on the state level with state legislation and state funding. And as Jimmy Lewis told you in Demorest, it takes money. And you're responsible for that. So I'm going to sit alongside Jimmy on that one and say that it will take money for some of these things, but the benefits can be enormous. The other thing that we are asking you to do is to become super intentional advocates for Georgia residents with the Georgia congressional delegation. Because some of the activities and opportunities listed in this document are being considered at the federal level. So I don't want anyone in the room or listening or you on the panel to think that you can avoid the opportunity to work with our congressional delegation on some of these. And if you do, if you miss that opportunity, then many of those programs are not likely to come to fruition. I will tell you that our organization, and I'm sure many of the people in this room, are working with the congressional delegation on the federal legislation and legislation like it for other healthcare providers to increase, to create federal programs that increase doctors, nurses, and other healthcare providers. So not every, I have not attempted in this document to include legislation at the federal state level for nurses, respiratory therapists, occupational therapists, or any other profession. However, some of the things at the federal level and at the state level certainly apply and should help incent the production of more healthcare professionals. So one of the things, obviously, is we're going to encourage you to incent existing programs to train more physicians who are available to go to the rural areas. And one thing that we have learned from experience, recent experience, and I'm sure the healthcare professionals such as Dr. Stephen Milan, who I'll introduce just shortly, know is that when you draw residents into healthcare training programs from the rural areas, they tend to stay. I'll give you an example in just a minute. So what are some of the current in-state successes that we've seen? Andrew College in Cuthbert, Georgia is a very small private nonprofit school in southwest part of our state. It is the biggest industry in that county, in Randolph County, by the way, the college. Andrew started a nursing program at the associate's level just a few years ago. They also started a respiratory therapy program. And what that institution does is intentionally goes into the high schools and generates enthusiasm and confidence in those high school students to then enter healthcare related fields. And so the program has turned out a number of associates level nurses and respiratory therapy. And I confirmed yesterday, 75% of those graduates remain in Southwest Georgia and are serving their neighbors, serving the folks in the counties where those students were raised. B.B. Putney Hospital in Albany works intentionally with high schools and career academies to recruit high school students to train as certified nursing assistants while the students are still in high school. And I'm going to commend to you that if you have not watched the video or talked to some of your peers, go and listen to or review the Senate and House Study Committee on dual enrollment for highly skilled students at younger ages. That's Senator Matt Brass and Representative Matt Dudley's study committee. And their first meeting in Albany is impressive. The content of that meeting is impressive. So that program provides clinical experiences in hospital facilities to expose high school students to environments where students can actually envision a career in healthcare. And then there are some wraparound services that PD in this program are doing to help support the students and to help mature the students. And then, of course, I want to mention Mercer University's medical school, which is all about, and its healthcare programs, which are all about helping incent more physicians to go to rural areas. That is the mission of that medical school. So there's a federal opportunity here that you can read about later. What I'd like to do now is ask Dr. Stephen Myler, who's the chair of the Department of Anesthesiology and Perioperative Medicine here at the Medical College of Georgia, to tell you a little bit about what NCG is doing to train and place more healthcare professionals in our state. Dr. Myler.
Good afternoon. My name is Stephen Myler. I am the chair of the Department of Anesthesiology and Perioperative Medicine here at the Medical College of Georgia. I have served on the department faculty for the last 21 years. I very much appreciate the opportunity to share with your committee insights and data on our physician training programs and their contributions to the physician anesthesiologist workforce in the state of Georgia. Our anesthesia residency program functions under the umbrella of the state's only public medical school and is one of only 2 residency programs in the state, and we review on the program. Our anesthesia residency program is a fully integrated 4-year program, which includes the categorical for inter-year, followed by 3 years of clinical anesthesia training. In addition to our residency program, we provide fellowships of specialty training in pediatric anesthesia, in critical care, in chronic pain, and we're in the process of adding the acute pain fellowship. For the purpose of this presentation, we reviewed annual graduation statistics for our anesthesia residency program dating back to FY13. During this period, we graduated 116 anesthesia residents. 22, or roughly 19% of these residents came from Georgia. The other residents joined us from other states or other countries. 45 graduates, or approximately 38% of the 116 graduated residents, stayed in Georgia. Of these 45 graduates, 15 joined our faculty and 30 joined private practice. Of note, out of the 22 residents who came from Georgia, 19, or 86%, ended up practicing in Georgia, which is more than twice the retention rate in comparison to the total group average of 38%. Like most states, Georgia is facing a severe anesthesiologist workforce shortage. Nationally, the numbers are very similar in Georgia. 57% of practicing anesthesiologists are 55 years or older. Our specialty suffered from the Great Resignation following COVID-19, with 4 years of retirements occurring in 1 year. And following this and the future waves of retirements, we are confronted with a serious supply deficit of anesthesiologists in their prime years due to low anesthesia resident training enrollment in the 1990s. The American Society of Anesthesiologists Center for Anesthesia Workforce Studies is acutely aware of these issues and is actively working on several proposed solutions. In the supply category of solutions, CMS is a major funder of graduate medical education positions. Unfortunately, this funding has been frozen with few exceptions since the 1997 Balanced Budget Act. Advocating for increased CMS funding and building private partnerships supported by private funding to increase residency training opportunities are among the high priorities. Locally, we have the following opportunities. to add anesthesiologists to the state's workforce. First, increasing the size of our anesthesia training program. Second, increasing the percentage of anesthesia residents from Georgia. And third, and very importantly, adding our department to the group of departments and specialties that have already been approved for the MCT 3+ program. Enrollment of MCT medical students under the MCT 3+ program would mean that these students would train with us and following graduation would serve the rural anesthesia needs for a minimum of 3 years. Finally, I would like to comment on the anesthesia care model in our department. Our residents, quote unquote, grow up witnessing in their daily training the benefits that a physician-led anesthesia care team brings to our patients. We are fortunate to attract a very talented group of CRNAs from Augusta University's College of Nursing year after year. Under the medical direction of a physician anesthesiologist, our CRNAs are a critical component of the care of our surgical patients. We have excellent relationships with our CRNAs. Our CRNAs work hard, have excellent skills, and support the clinical and training mission of our department. In the 30 years that I have practiced my specialty, I have not only enjoyed, but my experience has taught me that the physician-led anesthesia care team model provides by far the best care environment to serve the anesthesia needs of our patients. In addition to the physician's knowledge guiding the anesthesia plan, accounting for the critical nuances of underlying illness and the surgical needs, updating anesthesia plans based on new research findings and participating in this research, there are many examples of untoward events in anesthesia. The lost airway, the unexpected massive bleed, a life-threatening anaphylactic allergic drug reaction, a potentially fatal heart rhythm disorder are among the examples where a physician-coordinated team response will always surpass the emergency response of a single anesthesia provider, as would be the case for the independently practicing CRNA. Based on my long-standing experience, I'm very clear that the physician anesthesiologist-led anesthesia care team protects each member of the patient care team, the CRNA, the anesthesiologist, the surgeon. Most importantly, it reduces the risk of avoidable harm to our patients, as well as the liability risk to our health systems. It is my hope and strong recommendation that our deliberations propose solutions will focus on what is in the best interest of our surgical patients and seek to secure the same standard of care of the physician-led anesthesia care team model without bias as to whether this care is provided in an urban or rural setting. Thank you very much.
Thank you, Dr. Mahler. So I'll point you to page 2 of the document, and you'll see section 3 and 4. These give specific opportunities in which you can work with our federal legislators to adopt programs that solve problems and remove impediments from medical school graduates, both in this country and at international medical schools, to find residency programs that are necessary for those students who enter into practice. And there are some startling statistics in here about how many international medical school graduates, many of whom are from the United States, probably from Georgia, simply cannot find a residency program to complete training. So we're missing an opportunity. The fact is that there's a staggering number of medical students in our country trained here that do not match. That figure is in this document, if you want to drill down to it. So as Dr. Mahler stated, residency program funding is generally and largely through the Medicare and Medicaid program, through CMS. It's inadequate. It's highly inadequate. And if we want to make progress, to create more practitioners and to incent the pushing of those graduates to the rural and underserved areas, then we've got to change the way we're doing things. There's information in this document about legislation that would remove the stranglehold that ACGME has on on residency programs. So I'll leave you to read that, and in the interest of time, I'm going to kind of blow through this boatload of information. You'll see that there are loan repayment programs at state and federal level that are available and could be enhanced. Scholarships for medical students. Some of you have voted for state level incentives for rural and underserved care. Those are listed here with some recommendations. But again, I want to point you to what has happened in Alabama and New Mexico and other states to increase production of trained professionals. Now, one of the problems that comes when a medical school graduate does not match into a residency training program is the medical student is in what I call a neutral position. So there has been a great deal of thought by some folks in other states on how to make productive the time of the medical students while they're waiting to match to a program. And it's called assistant physician licensure. You see that in Alabama and Arizona and Idaho, to just name a few, the states are doing something to try to create productive time where those residents that do not match are able to go and work with physicians supervised by practicing physicians so that the student is maturing, is learning further, is getting clinical experience. And so we commend that program to you. You'll also note that there are programs in Louisiana, Tennessee, and in Washington State. So I'm not going to belabor the international medical graduate hurdles and impediments, but I would ask that you read that. So what can the state of Georgia do? Well, you could emulate what California, Texas, New York, Minnesota, and Michigan have done and sponsor more medical residencies. As I said, largely medical residencies are sponsored by CMS. So we're at the mercy funding of the federal government. We know how difficult that is. So I ask that you consider these seriously. I think one of the biggest problems in anesthesia that disincents an anesthesiologist to go to the rural area is what is known in the anesthesia community as the 33% problem. It's now the 24% problem because of recent reductions in Medicare funding for anesthesia services. When I say reduction in funding, I mean significant reductions in funding in the Medicare program, which is, as you know, is a huge population in Georgia. We've had that discussion and we'll continue to have that discussion about Medicare funding in our state. And so what happened in the 1990s was that when the federal government changed the funding formula for reimbursement of anesthesia services, I'm just going to be blunt and say it. Anesthesia and anesthesia practices got screwed. And that has never been corrected because of the way that Medicare and Medicaid fund, CMS funds Medicare services on a neutral basis. So why would a physician want to go to a rural area where it's almost probable that the patient mix is going to be all Medicare and Medicaid with very little private pay? Because the physician and the anesthesia practice is only going to receive a reimbursement that by comparison to other medical specialties is 24%. And I know Dr. Kirkpatrick knows very well all about this problem. So we're asking you to be intentional with our federal legislators and look at these bills that are being considered at the federal level, and to ask our federal legislators to act for the benefit of our rural and underserved communities. Now, in the interest of time, I'm going to get down to the lick log, and we're going to shuck some corn, the last page. I actually forgot one of the corn cobs I wanted to put in this, so I'll give that to you. You face challenges in recruiting medical personnel to rural and underserved areas. We know that. But the increasingly difficult challenge for you and for Georgia's public policy makers in the health room is keeping the few healthcare personnel you have now. Dr. Myler referenced the post-COVID retirement of physicians. We have seen significant retirement in anesthesiology. And it will take years, even if you act on all that is recommended here, it will take a decade or so for anesthesia providers of different types to be pushed forward through the pipeline. That post-COVID retirement it occurred in nursing as well, as you know. So here are the 10 things that I think you can do right now and encourage your colleagues at the state level to do. Surprise billing is not working. It is not working. At the state level, on the state surprise billing platform, we are seeing payers simply refusing to pay. I know that you passed 2 bills last year that are intended to address surprise billing challenges for medical practices, and we hope and look forward to working with the insurance commissioner and you to see those laws implemented and enforced. But I'll tell you, a medium-sized anesthesia practice, say in Middle Georgia, that has a $750,000 accounts receivable from a massive insurance company cannot survive. Because if they have $750,000 receivables from one insurer, they probably have just as much from other insurance payers. And those anesthesia practices are paying their CRNAs, their anesthesiologist assistants, and all of the team members that are required to provide safe anesthesia and periodic care. So we're not finished with surprise billing. And I will say on the federal level, that law is completely broken. Completely broken. The Texas Medical Association and other organizations have sued and won 3 times to stop the regulatory agencies that created that faulty regulatory structure to cease and to abide by the law. So I'll give Congress credit. They passed a pretty good surprise billing law that, if properly enforced at regulatory level, would begin to see money flow to medical practices. Number 2, adopt legislation requires adequate physician and facility networks by healthcare clinics. Basically, hospital-based physicians like anesthesiologists, radiologists, pathologists, and to a great degree, ER docs have no leverage against insurers in contracting, because those insurers know that those physician specialties must take every patient that walks through the door. I know that Senator Hatchett, Dad, is well aware of some of those laws and requirements and the burden that it places on the finances of the medical practice. So number 3, demand that Georgia's federal lawmakers fix faulty regulatory implementation of No Surprises Act, which I previously said. Number 4, adopt medical liability and premises liability legislation, which yield fair protections for patients and reduce outrageous and unsustainable verdicts, which are running more facilities and healthcare personnel out of the profession. Now, we know that the governor is leading on this, and we look forward to working with him. And Senator Hatchett, I imagine you'll have a little something to do with that in your role as board leader. Number 5, adequately fund the Georgia Composite Medical Board, the Georgia Board of Nursing, and all other licensure boards which struggle to process and issue timely licenses to qualified healthcare personnel. A physician, a distinguished anesthesiologist who has run major medical practices throughout this country is taking over direction of an anesthesia practice. I will not name the city. His license renewal in Georgia has been delayed for months. And he needs to be on the job right now.
4 months or 4 months?
FOR. It wouldn't matter if it was 4 or FOR. Because that's
All of
just,
it applies.
it's just too long. And I know that nursing board struggles because there are thousands of nurses seeking renewal. And I know that there has to be disciplinary and compliance activities by the boards. But in my impression, and most of you know, I've been around a few years, that the boards are completely inadequately staffed and funded. And frankly, I'll say it, that's on you. All right. The number 6, consider recommendations by the Senate Study Committee on Workforce Development and the Senate Study Committee on Occupational Licensing, which shorten the time to license of qualified personnel. So I know those 2 Senate Study Committees are doing good work. I certainly haven't seen their recommendations because they haven't posted them, but I imagine there's some good stuff there. And look forward to talking with you about that when we see those recommendations. What can Georgia do also? We increase Medicaid rates for physicians, especially those providing surgical and procedural services. Anesthesiologists are part of that service. Number 8, demand that Georgia's federal lawmakers adequately fund Medicare services. This is our 24% problem that I spoke of. Number 9 that I asked you to insert there is to urge the Board of Regents to start an anesthesiologist assistant training program at the Medical College of Georgia. Emory and South College in Savannah produce a number of AAs. I think together they produce 80 AAs a year. Many of those stay in there. It's time for the university system to join the opportunity to produce more AA students. And then finally, I ask you to maintain the quality of healthcare in rural areas by keeping physician-led healthcare in a team approach available to all Georgia citizens, regardless of the setting. With that, Mr. Chairman, Dr. Milo and I are happy to answer questions.
Thank you. I'm gonna just say thank you for coming. We're gonna try to keep it on schedule here, so I'll limit it. A couple questions if anybody has them.
Yeah, I just like to clear up something, and I know something about this from being a physician, but it's confusing that there are CRNAs, PAs that are anesthesia PAs, and then there are anesthesia assistants, and it might be helpful for people if you just briefly sort out who does what.
All right. Dr. Milo, you want to do that? Now in Georgia, PAs, physician assistants in anesthesia, are comparable everywhere else in the country to certified anesthesiologist assistants. When you passed legislation last year that had a glitch in it, the governor had to veto, that would establish anesthesiologist assistants separate from physician's assistants. And you'll see that legislation again. Hopefully we'll pass that with the required change in it. Personally, does that satisfy the work of Dr. Miller? Would you address the work?
The clinical responsibilities are the same for our CRNAs, for our AAs. They receive exactly the same thing in our department, which is what you would see in other health systems as well. So from a clinical perspective, they're identical in the way they're deployed in our operating rooms as part of our teams. The education pathways are different. CNAs obviously are going through the Bachelor of Nursing degree, whereas our AAs go through a pre-medical pathway. And so their education curriculum is separate. The other difference between AAs and CRNAs is that AAs can only be medically directed by us.
Yeah, thanks very much for some excellent information with a lot of detail. My top line question is this around the surprise billing, the Georgia bill, the surprise billing, the federal bill. And are you saying that in both places we have a decent bill, but when it comes to the regulatory enforcement, the way the regs are, the regs that have been done, and whether they are or are not being, so you have big insurance companies stiffing medical providers, is that it in a word?
That's correct. So I want to be fair to Commissioner John King.
Right.
He has been involved in legislation that you passed to strengthen his authority to hold insurers responsible and to make the arbitration process fair to both sides. But right now, it just isn't working. And at the federal level, it's not working at all. Because the three regulatory agencies that were responsible for writing the regs on the federal bill just summarily changed the mechanisms. And all of the changes enhance the position of the payers.
Which indicates that the payers have been very effective lobbyists behind the scenes with the regulatory agencies. We know how big it is. So that's a real factor that I'm taking from your presentation, because that's legislators that pass laws and governors or presidents that sign the bill, put it into law, and then it's been subverted by the insurance industry at the regulatory level, when the rules and regs and the enforcement. That's it in a nutshell.
That's it.
Yeah.
Thank you for your description of our challenge. Mr. Chairman, I know that our time is up. When we first talked about this study committee, I committed to you that the GSA would come forward with solid recommendations. And we believe that this is 85% of the best recommendations and opportunities that are available right now. And there are other good minds in the room, and others will testify. And again, I say that many of the activities in here can be duplicated for nursing and other medical personnel and healthcare personnel, those incentive programs. I want to assure the committee that, and everyone in the room, that we are going to make this available to Ms. Bernita Simmons, our latest updated version, which I need to do a couple of updates. We'll send it to her, and it can be available to any through her. And Ms. Simmons has hard copies of the DSA presentation available if anybody wants those.
Okay, and I think Senator Walker is joining us on Zoom. Has a quick question.
Yes, sir. Can you hear me?
Gotcha.
I appreciate it, Mr. Chairman. And Jet, I appreciate your comments. I certainly think I could agree with several of your recommendations, and I look forward to seeing your document. I think we need to increase the funding to the Composite Medical Board, give them the resources they need to do their job. I'm in favor, unless I'm convinced otherwise, that nurse protocol agreements ought to be able to be just submitted to the Composite Medical Board and kept on file and not require action by the Composite Medical Board unless there's a problem. In other words, submit it, put it on file, deem it approved. that would take some of the workload off of them and speed up the process for getting our advanced nurses working. I don't want to miss this opportunity to, and I don't mean this in an adversarial manner at all, but I'm wondering if you could speak to your concerns or your clients' concerns on the legislation I tried to pass last session, where rural hospitals are struggling to hire surgeons because these hospitals don't have an anesthesiologist on staff, and they're using CRNAs in the operating room. And we just wanted to change the language in the law to make it clear that the surgeon was not supervising the anesthesiology, the administration of anesthesia, that the CRNA was responsible for that. Has your position changed? And if not, can you explain your concerns so that I understand that better?
Thank you, Senator. The GSA position has not changed because the GSA, as I said in my opening remarks, promotes and educates toward a physician-led healthcare team approach. And that is a team approach that is replicated across all medical specialties. If I were a patient, whether urban or rural, I would want as many responsible parties adding their training, their brains, and their hands to a rescue effort as can be. CRNAs are highly trained. Anesthesiologists, assistants are highly trained. But when a patient needs recovery, when the very things that Dr. Myler outlined in his testimony begin to occur, you want as many heads and hands involved in that rescue as possible. Senator, there is nowhere in Georgia that an employable anesthesiologist, CRNA, or anesthesiologist assistant is not working if the practitioner wants to work. That is to say that everybody that wants to work in anesthesia and is qualified in this state is working, and we need more. And that's what our testimony has been about today, to produce more anesthesia providers so that there can be some push down into the underserved areas. But I will say this, and this is me, this is not a position of the GSA, but I've worked for GSA since 1992, and this conversation has occurred every year since then. I would not want a surgeon that is not willing to take responsibility for the total care of me.
Thank you for coming today. I appreciate you bringing us your recommendations. I know y'all put a lot of time into it. We'll review it. Once you get it available to review that, we will make sure everybody on the committee gets it. Thanks for the time today.
And Mr. Chairman, I want to say that I have a meeting in Gainesville in just a few hours, and I don't want anyone to think that I'm disrespecting the testimony that will follow. Some of my coworkers are here, and I'll also be able to listen to this in my car. So I look forward to hearing.
I'd say, thanks for coming. We went a little over on that one, so I'll try to get us back on track. Megan Graves.
Mr. Chairman, I'm Megan Braff. I am the immediate past president of the Georgia Association of Nurse and Anesthetists. So I want to talk to you guys today about what a CRNA is and what we do. And I am very happy to be here today representing the over 1,700 CRNAs that we have practicing in Georgia today, who are taking great care of their patients. So what is a CRNA? Certified Registered Nurse Anesthetist, or CRNAs, are advanced practice registered nurses who specialize in training in anesthesia. CRNAs like myself practice in every setting where anesthesia is delivered. including hospital operating rooms, labor and delivery suites, dental offices, podiatrists, ophthalmology clinics, plastic surgeons, pain management specialists, and ambulatory surgery centers. And of course, all of the U.S. military facilities. CRNAs are the only anesthesia professionals compared with AAs and physician anesthesiologists with required critical care experience before beginning their formal anesthesia education. And I want to highlight that for a minute because what was mentioned earlier, when we talk about these absolutely detrimental things that can and do happen in surgery, things like a cardiac arrest or a massive bleed or something, hopefully for most anesthesia practitioners, that's maybe a once or twice in a career sort of occurrence. But what is so special about CRNAs is that our time spent at bedside in the ICU dealing with patients, we're dealing with those on a daily basis. So we are very easily able to recognize some of those small, more minute clinical signs that tell you and give you a good telltale sign that something is about to happen here. And so that is what really positions us to be able to take great care of those patients in surgery when those unfortunate events do happen. CRNAs are, of course, among the nation's most trusted professions, according to the Gallup poll as well. So let's talk about our education and training. Today, CRNAs have full practice authority in every branch of the military, and we are the predominant providers of anesthesia care to U.S. military personnel on the front line, Navy ships, and aircraft evacuation teams around the globe. If we're good enough to stabilize a patient on the battlefields, we're good enough to take care of you for your elective surgery, I promise. A CRNA must complete 7 to 9 years of education and experience. And all students entering an accredited CRNA program must be enrolled in a doctoral program. After 2025, all CRNA graduates will have a doctorate in nursing practice. CRNA graduates have an average of over 9,000 hours of clinical experience, including 733 hours of nursing, over 6,000 hours as critical care nurses, and almost 3,000 hours during their anesthesia program. And I want to talk to you, you're going to hear a lot of facts about clinical experience and, hours on the job. And these hours that we're counting are hours spent in the operating room. We feel like it is unfair for other specialties to claim that they have exponential amounts of clinical hours when those hours actually spent asleep in a call room. That's not really on the job experience. Unlike physicians, CRNAs must be board certified to practice, and they are actually required to repeat that board certification every 8 years. So we are staying up to date on the newest and latest innovative technologies, and we hold ourselves to a very high standard. Also, I want to talk about the students that are going through these programs. These CRNA students, their education is privately funded, meaning that they're taking out student loans like I did, or they're paying for it themselves. Unlike physician residency programs, which are taxpayer funded, these don't create any sort of a burden or any sort of a tax burden on our residents here in Georgia. And then also with mentions to the AA program, the AA programs, they have more of a fast tracking plan. And so if you are mass producing these anesthesiology assistants, they require physician supervision, as we mentioned to you earlier. And when we already have a lack of physicians that can supervise those people, who's going to supervise them? So one of the benefits of CRNAs is that we actually work under the direction and supervision of a duly licensed physician, which is the operative surgeon. So how can CRNAs help rural medical personnel shortages? CRNAs provide anesthesia services in rural areas so we can increase the access to surgical procedures and reducing the need for patients to travel long distances for care. CRNAs collaborate with other healthcare providers to develop comprehensive plans for patients in rural areas, ensuring that they receive the necessary medical attention. So one of the things that we heard about in the first study committee was talking about trauma stabilization and the trauma network. And that's something very much that we do in rural Georgia. If a patient needs to be transported to a higher level of care, will be called to the emergency room, help start centralized large bore IV, start fluid resuscitation blood, get that patient stabilized so that they can get out and get to a higher level of care. Anesthesiologists will not practice in some Georgia hospitals because unfortunately those hospitals can't afford to pay as much as they would like to earn. A CRNA can deliver anesthesia and can keep the hospital's operating rooms open to deliver surgery to patients as well. So best practices from other states, I actually have an update to this slide. We now have 24 states that have enacted legislation that allows the governor to inform CMS that their state will now opt out of allowing CRNAs to practice without physician supervision. This allows hospitals and facilities to collect funds from CMS for CRNA provided healthcare and anesthesia services, giving much needed revenue to these rural hospitals. These states have seen increased access to care, improved patient outcomes, and cost savings. State legislation enabling governors to opt out has proven to become an effective solution to addressing rural medical staffing challenges. And what's interesting now is that of the 24 states that have opted out, not a single one has reverted back because of patient outcomes or issues with that opt-out. So what we do here in Georgia, as y'all saw this spring, SB 102 and HB 445 were both introduced, and these bills simply updated the out-of-date language. This language was previously updated back in 1994, where it said that we worked under the direction and supervision of a duly licensed physician with training in anesthesia. So that kept us in that same 1-to-4 ratio, working directly under a physician anesthesiologist. When that physician anesthesiologist was struck from that language, it allowed us to go into rural Georgia, where there are not physician anesthesiologists, and work directly with the surgeons to help increase that access to care. So what this bill essentially was attempting to do was trying to take some of the burdensome language where you see direction responsibility. A lot of these attorneys will see liability and think that the surgeon is going to be liable for the CRNA's action. When in fact, we actually have the same medical malpractice policies that physician anesthesiologists do. And so the law doesn't show any change in responsibility if there is some sort of legal action. The Governor's Workforce Commission recommendations, and this is a direct quote. Rural areas can often operate on skeleton crews of healthcare workers that must redirect advanced procedures to better equipped facilities. For instance, this is especially true of surgical procedures that require anesthesia, because while a rural facility may have a surgeon, they may not have an anesthesiologist. In many rural areas, demand for anesthesiologists is filled by a nurse anesthetist who must currently operate under the license of a physician, even if that physician does not have expertise in anesthesia. Providing the highest quality of care. CRNAs operating as the sole anesthesia provider has a track record of a safe delivery model. There are numerous peer-reviewed studies that have shown that CRNAs are safe, high quality, and cost-effective anesthesia professionals who should practice to the full extent of their education and abilities. In a 2010 study published by the Journal of Nursing Economics, it indicated that CRNAs acting as the sole anesthesia provider is the most cost-effective model for anesthesia delivery. And there's no measurable difference in the quality of care between CRNA only and other anesthesia delivery models. Georgia's opportunity. Georgia has the opportunity to adopt legislation to address its rural medical personnel shortages by allowing CRNAs to provide anesthesia services without supervision by a doctor who may not have any experience in anesthesia. We can improve access to care in rural areas. Many hospitals in Georgia, including Piedmont, Brady, and Hometown Health, were all in support of SB 102 to allow Georgia facilities to deliver anesthesia without the outdated and expensive physician supervision required. Also, I hope you guys were able to get one of our folders today. I think we have some over there left, but it's got some really interesting infographics here about the efficiency-driven anesthesia model. if you really want to get into questions about staffing. We also have a map for you that shows the no physician or direction requirement of CRNAs and laws. So you can see it's most of the US actually. This one covers the distribution of anesthesia providers here in Georgia. And you'll see in white, there are no anesthesia providers in those counties. And then on the flip side of that, it has it broken down by county to tell you how many anesthesia providers are there. Then there's a couple too about the different policies and benefits of CRNAs. There are also some studies in here that show the facts about CRNA safety and what we do. And then there's more on the education and training of the CRNAs as well.
Your question.
Sure.
So, thank you so much for your presentation. One of the issues that was raised by, Dr. Myler, I believe, was that things can go wrong in the operation, right? So heart attacks can happen. I don't know, a host of things can go wrong. Can you speak to who else is in that operating room in addition to the CRNA who may be trained to help address some of those,
Absolutely.
those problems that go wrong?
Absolutely. So, you know, in a traditional surgery, depends if it's a very high risk surgery, also you're going to have more people, more providers kind of available. If it's just a run of the mill, we're taking out your gallbladder sort of surgery, you're going to have an operative surgeon. He or she may have a first assist on the field as well. There's at least one circulator who's a registered nurse in the room. And then there's an anesthesia provider that's providing that anesthesia. Now, depending on how big that facility may be, if you're in an outpatient surgery center, you may have 2, 3, 4, 5, 6 or more rooms that are staffed in a similar manner. Or if you're in a large hospital, especially a large teaching hospital, you could have up to 30 operating rooms that are all similarly staffed.
And so to be clear, there is someone, I didn't go to med school, all I learned is from Grey's Anatomy. The surgeon operator, whatever, have you heard of him?
The operative surgeon.
The operative surgeon.
Yes, ma'am.
It would also be trained in massive bleeds, heart attacks, like addressing these types of issues as well. Is that true or am I wrong
Right.
about that?
Yes, yes, they are. And again, if there is a situation in the operating room where a patient is suddenly not doing well and we are doing, you know, life-saving measures in there, it's an all hands on deck situation. So if you aren't currently allocated with a patient on the table, you are in there helping, you're starting an extra IV, you're sending someone to blood bank to get the blood. Someone from pharmacy is showing up to help assist in a code if needed. There's multiple hands on deck.
Yeah, that's one follow-up question.
Yep.
And so one of your pieces of educational material says that this bill is trying to do what we already do in Georgia. So can you just like paint the picture for me? You have a CRNA who's in the operation room with the operative surgeon.
Yes.
Where is the anesthesiologist?
Well, that would depend. There's multiple places in rural Georgia where I've worked where there isn't an anesthesiologist at all. So if Dr. Bo Hatchick here wants to do a C-section on someone, he'll say, hey, Megan, we've got a C-section that we're going to do in 30 minutes. Like, yes, sir, I'll be right there. I'll go, I'll see the patient, I'll do a pre-op assessment, make sure that the patient can have a spinal or if they need to be put all the way to sleep for it. That's all my decision and my call. And then I take care of that patient. So I actually don't have a DEA license. So that's why this is not DEA license, meaning that I have prescriptive authority. So I can write on a piece of paper and give you a prescription to take home and get filled. So you can get your pain pills, your blood pressure medicine, whatever it is that you need. Because as we've mentioned multiple times, this bill was not a scope issue. So this bill didn't allow me to do anything I didn't already do. So I actually use the facility or the surgeon's DEA number, and that allows me to pull the drugs that I think are acceptable for that patient to get them through that anesthetic.
And there's no anesthesiologist around
Correct?
today, right now.
if we were down there, this is Hawkinsville, Georgia. I used to work down there at Taylor Regional for years, covering call. And I would get called to the ER. I would cover labor and delivery. I would cover anything that, was like an emergent surgical case that needed to go during the weekend. No anesthesiologist there.
You doing your presentation? Because I have questions, but I don't know if you're finished.
Oh, yeah, we're doing questions.
Yeah, I had two questions. First of all, I'm trying to understand about the opt-out.
Yeah.
If that's something that the governor can do after consulting with the medical board and the nursing board, where is that in Georgia? Or is that conversation happen? Because if that happens, then why do you need legislation?
Right. We have been discussing that and when the best time to approach the governor is for an opt-out. Historically, in the past, he hasn't always seen eye to eye with nurses. And so it's been a difficult conversation in the past. I think we have created a much better environment to have these conversations with him. And so we're very much looking forward to speaking with him about it.
Okay, so that yeah, and my other question is, are you in support of, when I first got out of school, I knew a lot less than I knew 5 years later. Or, as time goes on, you get experience. Are you guys in support of any kind of experiential requirement for people that are wanting to practice independently in a rural area, let's say, versus a urban area where there's more backup?
Well, all of our students that graduate from our doctoral prepared programs spend lots of time in rural Georgia. They see exactly what more of an independent practice is. And then they also spend time in urban areas and see what a more medical direction type model is. So these students are very well prepared to go out into rural Georgia to work independently. I did it out of school and I worked with that anesthesia group for about 12 years.
I just wanted to clarify the opt-out versus like
Okay,
legislation.
That, if you don't mind.
Yeah, sorry. Wesley Parker, also from Anna. So I just didn't want to conflate the two issues. So opt-out and what our legislation was last session are two separate things. Opt-out deals strictly with billing. Doesn't deal with the day-to-day service of anesthesia. What our legislation was trying to do is take away that word, really, responsibility, that is misleading to surgeons that say, I don't know anesthesia, I don't want to be responsible for anesthesia. Why should I be responsible? They shouldn't. And in many states, I think y'all see there's 30 states now with supervision or direction language in the state law. That's why we're trying to make that legislative change to help open up those areas to where now surgeons, like we've told y'all in the past, the federal prison up here isn't doing surgeries for almost a year and a half now because the surgeons won't work with, they don't want to take responsibility for CRNAs. We're shipping the prisoners to the hospital here to have treatment because they can't do them at the prison. So that's just one way it's affecting us. But opt-out is a strictly billing issue, has nothing to do with care.
Yeah, unfortunately, billing and care can't really be separated, particularly in the rural areas where the payer mix is much
Well,
higher government payers.
Yeah, and the opt-out just opens up basically the fact that rural facilities can get paid for CRNA care without having to have a quote unquote physician supervisor as heading the anesthesia department. But it wouldn't affect how we deliver the anesthetics.
Well, I just, Wesley was just saying, so there's a situation that exists, but we're operating like it doesn't exist. And the situation in the real world is that they're not anesthesiologists in a lot of these rural settings.
And they talked about the 33%, 24%. And that is what it comes down to, dollars and cents. To attract people out to certain areas and these fair rural areas, it takes a special person to want to live out in those areas. You're either born there or you just really like those areas, yeah. But you pretty much, these rural hospitals, they work on a very, very thin line of dollars and cents. Most of their dollars that they have to keep open are from surgical cases. Really, no other department in the hospital really raises money so that the hospital can stay open. So without anesthesia and without surgical care, those hospitals tend to close.
And then you get the care deserts that we're dealing
Right,
with,
right,
the labor
right.
and delivery care deserts, and increase in maternal mortality and morbidity. It's the snowball. It's just the
I think the statistic is 80% of rural anesthesia done in this country is CRNA across the nation, so. Very few
Well,
times
that's
we
a-
can find an
that's a-
anesthesiologist in those rural
That's a
areas
very potent statistic.
because they just won't make enough money to work their life.
Yep, one more thought.
And it actually may be a better question for you, the attorney, but I'm curious, I'm very concerned about something going really wrong in the room and knowing that my loved one gets optimal care. But in the event that that does not happen and there's a death, isn't everybody in that room gonna be sued no matter what? And the whole hospital, is that? not
Yeah.
correct? And so when these physicians say that they don't want to take responsibility of the anesthesiologists, they're all gonna be sued anyway, correct?
Yeah, and I would point out the case law from, gosh, all the way back to the thirties has pointed out that CRNA is liable for their actions. Yes, in a malpractice case, everybody gets sued and then they sort of tear down who's really responsible. As long as a operative surgeon does not inject themselves into my anesthetic, such as they told me to give a medicine or give something, I gave it and it caused harm to the patient, then that surgeon can be held liable. But there is no case law out there showing that a surgeon supervising a CRNA is liable for their actions.
Thank you all very much.
Thank you.
Thank you, Mayor.
You're doing well.
We've got Anna Adams next, and then after Anna, we're gonna take a quick break, and then we'll come up with David.
Thank you, Mr. Chairman. Members of the committee, I appreciate the opportunity to be here today. I feel like the two previous speakers did a lot of hospital work for me here, and so I will not reiterate any of the things that they said, but I am Anna Adams with the Georgia Hospital Association. I am the Executive Vice President of External Affairs there at GHA. We represent 145 hospitals across the state of Georgia, ranging inside from small rural all the way up to large urban system facilities. And so today I am honored and thrilled to get to talk with you about the specific challenges that many of our rurals are having with recruiting medical personnel and just the workforce. So I'll start with a statistic. I pulled the openings today in the state of Georgia for clinical positions in hospitals, and it currently sits at 14,718 clinical positions open in our hospitals in the state. And I'll add a caveat to that. Hospitals in particular are not going to post 16 ICU nursing positions if they have them open. They're going to post one, and they're going to take applicants for 16 people. So this number is very likely a much lower amount than what hospitals are currently recruiting. Another statistic, Georgia is actually a net exporter of nurses. So many of our nursing graduates in the state are leaving to go to other states. So as we continue to put resources into our nursing program, have them graduate additional staff, we're having those leave the state of Georgia, and we're not able to keep them in our state. Last legislative session, to Ms. Brack's point, GHA can add us to your list, was supportive of Senate Bill 102 and House Bill 447 to allow CRNA that extra ability to practice in our rural areas without fear of surgeons, maybe pushing back a little bit. And this is so important and vital to our rural hospitals, especially to Ms. Brack's point, because their margins are so razor thin. Those surgeries that they're able to do are sometimes the difference between a negative margin and a positive margin. And so we want to ensure that hospitals have the ability to hire staff that is both highly trained, is offering quality care, and we do feel that the CRNAs that we have employed are able to do that, and we trust that. Many of our hospitals, as they are hiring staff members who are clinical, not just CRNAs, but nursing staff, do extensive training at the hospital site itself outside of what they're getting in their school setting. So if you have concerns about quality, patient safety, potential threat, because our hospitals are putting in that extra work to make sure that they have that extra training. So GHA supports efforts to ensure that clinicians can provide care to the full extent of their training and education. This means maximizing scope of practice, which also controls the cost. So that is our current position, and I want to be clear that GHA is not necessarily advocating for additional scope of practice for freestanding facilities or for certain providers to hang their own shingle, but we do want to make sure that in the hospital setting in particular, providers can maximize that scope of practice. As you're thinking about charges, especially from a hospital standpoint, having lower level providers who are not physicians provide that care allow for hospitals again to maintain that positive margin. So if they have the ability to do it, if they're doing it in a way that's safe, we want to be able to let them offer that service to them. It's easier to recruit some of those providers from rural areas than it is for physicians. Someone made the point earlier that some of these physicians don't want to come to rural areas because of the reimbursement. It is very difficult for rural hospitals to have adequate reimbursement from our insurers, especially. They don't have the negotiating power. They're offered very low rates, and that continues to fall year over year. And so without the ability to be reimbursed for those services that they're providing, hospitals have had to come up with creative ways to offer those services. Labor and delivery, I think, is an excellent example of that. I keep referencing Ms. Brack, but she talked about labor and delivery earlier. We're seeing hospitals, especially rural hospitals, making the decision to close their labor and delivery unit.
Yeah.
And we often get the question, why is that?
Yeah.
Labor and delivery is not traditionally a service where hospitals are making more money than they're having to spend to offer that service within their community. But one thing I think a lot of people forget with labor and delivery is that you don't just need a labor and delivery room. You need all the ancillary services, which means surgery services, anesthesia, lab. And so if you can't recruit those providers to rural areas, you can't offer that service of labor and delivery. So it's one of those examples of there sort of being a snowball effect. You can't recruit one, you can't offer the services that they support. So we continue to keep our finger on the pulse of our members. What is it that you're having challenges with within your community? What are the things that we can help you advocate for? And from a workforce perspective in particular, when we ask them, what are the challenges that you have to recruiting these healthcare professionals? Number one is not enough graduates. And I think we are all aware that our schools are at capacity, they're graduating as many students as they can, but there are still some barriers there to the number of students that they can graduate. One of them is an issue that we have with the Georgia Board of Nursing. I think they are working to try to correct that, but there is a current requirement for the percentage of full-time versus part-time staff members, faculty at these institutions. And many of our hospitals that have partnerships with those local institutions would love to be able to offer some of their own clinical staff as part-time faculty, but the current part-time versus full-time ratio doesn't allow for that. So that's something that's a simple rule change at the board level that doesn't require legislation, but would have a pretty big impact as long as the school has the funding to employ them. Another challenge that we are hearing from our membership is that the workforce is not always very qualified. And I think as we push through some of these nursing students, especially during COVID, when they had to do a lot of virtual training, they may not be as qualified or may not seem ready for some of the hospitals, which is why so many of our members have implemented and are doing on-site job training for those clinical services. Another challenge is that the workforce is unwilling to locate to rural areas. We touched on that a little bit, but that's not a surprise. And then finally, from a rural perspective in particular, they find that they can't compete with other hospital facilities when it comes to reimbursement for those clinical providers and certain other incentives that they can offer them. Rurals just don't have the margin to be able to pull staff into those areas. And so therefore they often find themselves understaffed, relying on agency staffing, which is far more expensive. And when faced with those challenges, again, another question that we've asked our members, what decisions do you make when you have those significant workforce challenges? They are citing closing beds, closing services like labor and delivery, increasing shifts for the nurses that they already have, which leads to burnout and overwork, and then there's nurses potentially leaving. They're offering incentive pay where they can, and they are again turning to staffing agencies. So these are just some of the solutions that they're having to employ, but it really is impacting access to care, especially in those rural areas. And so we want to do everything that we can to make sure that they feel supported, and that does come down in a lot of cases to funding. And so we would encourage you as legislators to consider additional funding opportunities for nursing students, loan forgiveness opportunities, potentially incentives for hospitals to become teaching programs. Those are just some options to think about if you want to get that workforce out into the rural areas. There are a couple of recommendations that came out of the governor's statewide healthcare workforce commission that have not yet been implemented that we would still love to see. One of them is a quick start academy for clinical staff. This is very similar to what happens when you see a big new industry come into the state of Georgia and you need to train a lot of people very quickly. If you could do that for CNAs and certain other clinical providers that are lower level but assist our RNs, it would be incredibly helpful as long as they have the scope of practice to match that. So that's an option. An earn to learn program, so that these clinical providers can work while they're in school and go ahead and earn a wage while they're continuing to get that training. And then again, we mentioned scholarships and loan forgiveness. When asked what clinicians our hospitals need, the number one answer is bedside nurses. After that, it is the allied health professionals. They're asking for CRNAs specifically. They're asking for medical technologists, medical lab technologists, phlebotomists. So these again are all the ancillary services that we need to be able to offer standard hospital care, inpatient, surgical, etc. And then food services, environmental services, things that are not clinical in nature, but are integral to hospital operations. So those are the challenges. I've given you a couple of recommendations, and I'm happy to answer any questions that you have.
Thank you.
Just one quick one. I just, a couple days ago, read an article about a big study that more than 500,000 RNs are projected to leave the profession in 4 years, not just change jobs or leave their position, but it seems to be understaffing as a contributor, and also burnout, which is linked with understaffing. Did you all have any specific recommendations regarding that?
It's really a double-edged sword, because the problem is also kind of the solution, right? So we do see a lot of nurses retiring. We see a lot of people that are burnt out post-COVID. There have been some morale challenges from some of our hospital staff as well, when they have to work alongside staffing agency staff who come from out of state, and they may not necessarily be familiar with the hospital's EMR or the hospital's protocols and procedures. And so the in-house nurses are having to then train the agency staff, which are inherently making more than they are. And so we are continuing at the hospital level to try to incentivize our nurses, to try to make them feel important, to try to make sure they understand how valuable they are to the organization. But I think the question that you're asking kind of goes hand in hand with the question of why our nurses that are graduating going to other states and not staying here in Georgia. And many of the nursing agencies and associations nationwide cite the scope of practice on that. And so I do think that some measured changes to allow for those providers to operate in a more efficient way in the hospital setting in particular would be helpful.
Just one follow-up, Mr. Chair. So in terms of retention of nurses that are already trained on, they've been on the job, keeping them, I'm very interested in that. And people who are nearing retirement, if you could find ways to convince them to hang in there for another 2, 3, 5 years, that might really help the shortfall that we're trying to, build the workforce things and whatever. But are you guys working on that at all?
The hospitals are doing kind of their own things individually, and what we're finding is that for each facility, it's a little bit of a different approach. But I do think for those nurses that are nearing retirement, they have such a wealth of knowledge. And so even having them have the ability to be part-time staff at a facility to train new nurses would be helpful, I think, in keeping them in the workforce for a couple of years longer and impart that knowledge on the next generation of nurses. So we are open to suggestions if you have any. I know many of the hospitals are asking their nurses through nurse staffing committees, et cetera, what is it that you need, how can we help you? But it's just varying by facility.
So you spoke about people bridging the gap by having staffing agencies come in to bridge the gap. Can you talk to me about what's the difference? Is it simply pay? Because obviously, if you have a staffing agency that's able to staff a rural hospital, that means that person has relocated, whether it's temporarily or for months at a time, but they're living in rural Georgia. So you overcome that hurdle. Is it just because they're getting paid more money that they're willing to work in those places? Is that the gap?
You know, that's a good question, and we've asked ourselves that same question over and over. I think that there is a different generation of workforce now that likes the ability to have a 12-week contract and go somewhere new. I mean, it's exciting to travel, it's exciting to see new places. And, you know, I'll add to that, it's really incredible experience to see those different types of facilities from the nurse's perspective. When they do go to a community under contract, they're often living in long-term housing, which is a part of their contract, but their pay is generally 2 to 3 times that of the directly employed nurse. And so the hospitals just simply can't keep up with that. Now, I'll say that what we're paying from a hospital perspective to the agency is more than what the nurse that is getting themselves. And so there is an overhead there. It's a significant overhead. But it does sometimes breed.
So the nurses themselves, then, how much more are they getting? Like, what is their take home compared? So K is a settled, this is my hospital where I work nurse, and I am I want to move every 12 weeks nurse. What's our difference in take home pay?
It's gonna depend on her level of education, how long she's been at the facility. But generally speaking, I'm gonna say at least double.
And I'm not paying for housing expenses. And one follow-up question. So a number of the hospitals within Georgia have multiple locations, right? So if you work in Piedmont, you can work in Atlanta, you can work here. Are there shared networks of nurses that, you know, get to have the travel experience but stay within the state of Georgia? Is that something that we do?
I think some of our hospitals, especially systems, have experimented with that to see if their, you know, nursing staff are willing to do that. I don't know how well that's working. I don't have anecdotal data or stories that I can look into that. So that's really.
One thing you said is the bedside nurses, number one thing that y'all are looking for. What do you see is, I guess, an issue with not being able to get the number of nurses to the hospital that you need? Is it a recruitment, education? Is it, I guess, what would you suggest us look into to help solve that?
Georgia's not alone in this, I will say that. So every single state is trying to deal with this problem right now. First and foremost, there are not enough people to do it. And so we've got to find a way to graduate more people, to get people interested in providing clinical care, to get people interested in being a bedside nurse, number one. Number two, we have to make sure that our schools have the resources to be able to increase their class sizes. And that they have the ability to hire faculty and pay faculty so that they can accommodate those class sizes. But I'll add that one of the issues in not having enough staff, we talked about bed closure. When beds have to close on an inpatient basis, it means that patients who are in the emergency department can't be admitted because those beds are not open, which means that our EMS workers who are bringing in new emergency patients are standing there waiting for an emergency department bed to open, which means that there's not an ambulance out in the community to respond to additional calls. We're seeing the same workforce challenges in nursing homes, which delays our ability to discharge those patients. So the workforce shortage is impacting all of healthcare, post-acute, acute care, et cetera, and it's creating a snowball effect that I think has many of the nurses feeling overwhelmed and feeling a little bit hopeless, frankly, that because there's just no end in sight. And so we've got to have more bodies.
Earlier, someone presented about Andrew College, how they're recruiting going to high school. Is that a unique thing that schools are doing? And I guess my question is kind of twofold. Right now, in the state of Georgia, the number of nursing programs, are they full?
It is my understanding that they are full.
We need more nurses being trained each.
I think there's also a delay in the licensure process, like there is in many of our other licensure processes. Is that correct?
There is a significant delay in the process, and we had an issue not too long ago with nurses who were trained outside the United States who had actually not taken the NCLEX, and so they had what was not a valid license, and a couple of those came over into Georgia, and so we're trying to sift through those new applications to make sure that they are in fact valid, they've taken the NCLEX, et cetera. So there are some challenges at the nursing board level for things like that, but then it is volume, and it's helpful for nurses to have those interstate licenses, because especially if they're agency staff, it's easier to move them in and have them get a job and work
Is the,
in a hospital.
Are you talking about compact?
Yes,
is the delay in licensing from graduation from nursing school, are you licensed or coming from one state to another, or is it just across the board?
I think it's both.
Okay. Anyone else have any questions?
Just one follow-up. You talked about the Quick Start program. Can you say more about that? How quickly, in theory, could we get, I don't know, a bedside nurse, since that seems to be one of our number one issue? How quickly could we get a bedside nurse bedside?
So I don't, from an RN perspective, I don't think that's something that you can expedite. But for an LPN, which is somebody that helps nurses with when patients press the call button, or helping them with tasks that they need help with in their room, that would be much faster and would certainly help free up nurses so that they can do more direct patient care in an inpatient setting.
Thank you very much. So it is 1:38. We're gonna take a quick break and we'll start back at 1:45. Sean. Yeah. I was, that's sharp for 1:45. Next we have David Hess. We're ready?
Right. Thank you, Senator Hatton. Thank you. Welcome to AU and MCG. You know, we're the 13th oldest medical school in the country. Go back to 1828. We're the 9th largest. Next year, we may be larger than that. We'll probably be the 3rd or 4th largest. So, actually, just go back one side. I want to show this weekend, we had our white coat ceremony. That's the ceremony where everybody gets their white coat and initiated into the physician profession. We had 264 students, and that's in front, the picture, we didn't do the white coat ceremony there, but the picture is the old medical college. That goes back to 1833. So we've got great history and great tradition now. Thank you. So I think most of you know this is from our old Georgia Board for Healthcare Workforce, and everything that's green, yellow, and blue is short of physicians. And these are primary care physicians. Dr. You heard from anesthesiology, and Dr. Stefan Mahler is also a shortage specialist, but particularly anesthesiologists and neurologists, et cetera. But we'll focus initially on primary care physicians. You can see how many counties don't have an OBGYN, 82, more than half the counties. And we ranked, I think we're 49th in the country in maternal mortality. I think only Louisiana has higher. So we have a lot of problems with health outcomes, particularly South Georgia, but really all of Georgia. And as you can see, there's hardly a county that isn't short in some way. Next slide. And MCG is all over the state. We say Georgia's our campus. All those white dots is where we have medical students rotating. So we're literally in all 4 corners of the state. We're in Atlanta. We're in, we have the Southeast campus, Savannah and Brunswick. Southwest is Albany, where we have students all over the Southwest. In the North, we have Rome and Dalton. We have an Athens partnership campus with UGA. And then we call this, you're in the Middle East. The only term we have left. So you're in the Middle East. Thank God we're not in the Middle East right now, but we have students all over these areas. So we have 204 students that do all 4 years here and 60 in Athens, and soon in Savannah we'll have 40 students there. So medical school is like training a fighter pilot. It takes a long time. Fortunately, we have really good applicants to the medical school. We get really good ingredients. Next slide. So we completely changed our curriculum in 2019 to 20. Unfortunately, the pandemic hit us. We changed our curriculum. We didn't plan it that way. So our students went through a little bit of turmoil. So we changed our medical school to basically be done in 3 years instead of traditional 4. As you know, our friends at Mercer have a 3-year medical school. But all of our students can potentially finish in 3 years. And the ones that do and want to go into residency will be pathway 1. They could do a residency, but they have to do it in Georgia. And I'll get to why that's so important. Other students that maybe want to go into orthopedic surgery, anesthesiology, or neurology will probably take the advanced residency prep, where they spend their 4th year doing an enrichment phase. Elective times, you get a dual degree, you get a master's business administration, you get a master's in public health, or you can do research. So there's a lot of options. So there's a lot, this is like a restaurant with a great menu. There's so many things to do that we really have to counsel and direct our students early, kind of what do you think you want to do? And then they have so many elective choices, you kind of have to guide them. Next slide. So that is a very innovative curriculum. So thank to the Georgia legislators, the Senate and the House, Governor Kemp, and all of you, thank you, a million thanks. You're responsible for this program. We have a program called the Peach State Scholars. So these are the students on the pathway 1 who finished medical school in 3 years. Medical school is traditionally 4 years. So we cut off here. They hardly have any time off. We give them the holidays, December off, but it's pretty much straight through. And we've had our 3rd class. The 3rd class, we just have 9 of them that are down at the bottom, 8 of them. No, I can't count 9. In the previous years, we've had about 6 per year. So these students in the 1st year of medical school go through a rigorous interview process and decide if they want to practice in underserved Georgia. Because the deal is, we'll pay your tuition, scholarship for service. If you do your residency in Georgia, and then you practice 2 years, you get 2 years of tuition in an underserved area. Now, there's a lot of underserved areas. But that's the deal here. And it's really, really important because we are a net exporter of medical students. And so I'll get to the end, we have a shortage of residency slots. So we educate medical students. We do a really good job educating them, and then they go to Harvard or Stanford. That's great, but we want more of them to stay here. Or if they go there, come back. So this keeps them here because they do their residency here and they got to practice.
For how many years?
For as many years as they get scholarship. Presently, they get 2 years of scholarship. So it would be 2 years in underserved Georgia. When we get this, figure this out, and we can maybe enroll people in the program at admissions, we could do 3 years, but right now it's 2 years. And thanks to the state of Georgia, we got a $5.2 million gift from Centene Beach State Health a few years back. You guys matched that. And then you matched it the next year in our foundation kicked in. And we're continuing to get gifts, and you have a state match. So we now have an endowment to do about 25 of these students, every year, forever. Trip Umback, a firm that does economic analysis, said for every dollar you put in this program, and this is a third party, it's not us, you get $17.50 back, to the economy of Georgia, etc. It doesn't go to us, doesn't go to doctors, it just goes to, society and the state by, avoiding complex care, avoiding people going to the hospital, etc. So it's a huge return on investment. Thank you. So in our third year, Erin Latif, the director of the program, she's an OBGYN, and they get to choose from the following specialties. Primary care is defined very broadly by the Georgia Board for Healthcare Workforce. It's almost everything but orthopedics and anesthesiology and neurology, but it's family medicine, internal medicine, pediatrics, OBGYN, general surgery, psychiatry, and emergency medicine. Now, Dr. Myler would love it to be anesthesiology. He's got a good argument for it. So if in the future, we can expand it because there's shortages of specialists in this state, too. There's shortages in everything. Next slide. And here's our first graduates that are now in residency here. Here's our first 5 that entered the program. They entered the program a few years ago. Claude over there on the left is from Columbus. Luis is from Tifton. And so that's just an example. They're doing very, very well. They're in our residency, so we keep track with them, close track of them. And so these students will be out anywhere from 3 to 5 years. So residency is anywhere from 3 to 5 years. All right, so it does take a while for these students to get out there. Next slide. But it's a way to keep people in Georgia. So we have a very large medical school, for the 9th largest in the United States. How can we do that? Because we use the whole state. All right, we have a partnership campus with UJ and Athens. That's 60 students for 4 years, 204 here. And next year, we're going to have 40 in Savannah. So we're going to have another partnership campus. But that's the growth of our medical school there. So most medical schools are, about 150 students, 160. We're large. We have to be because Georgia's population is growing very fast. Next slide. And so we've had a very strong relationship with St. Joe's Camden. What we do is try to get relationships with health systems. That's the most important thing. So Paul Hinchy, who I don't think I'm wrong on this, better fact check me, is the longest reigning, continuous reigning CEO in Georgia. And we became friends a number of years ago when we developed a telestroke system in the Savannah area. And Dr. Michael is an MCG graduate, and she's the CMO there. So we've had students there for about 12 to 13 years, rotating at Candler Hospital and St. Joe's Hospital. It's a popular place, kids kind of like going to Savannah. But when they're at Savannah, don't think they're not in the rural areas. They go out to Statesboro, they go to a lot of rural counties and rural practices. They go to Liberty County, they go down to Brunswick, they go down to Camden, Georgia, which is far south as you can get in Georgia. So they're literally all over the state. So this has been a great relationship. And we really thank St. Joe's Camden. It works so well that Paul Hinchy would always tease me and say, when are you going to have the 4-year medical school, David? And I said, well, let's just think about it. But we've kind of been talking about this for a number of years. Next slide. And then this past year, thanks to Chancellor Perdue and Governor Kemp, Speaker Burns Parish, the General Assembly, all of you approved $1.7 million to renovate the Armstrong campus of Georgia Southern. Now, it just so happens, this worked out really well. St. Joseph's Hospital is right across the street from the Armstrong campus of Georgia Southern University. And on the Georgia Southern University, they built this beautiful school there of health professions. And it actually has some capacity. There's training nurses there, they're gonna be trained PAs that are not yet, they're gonna be occupational therapists, physical therapists. We went down there, we talked to their president, Kyle Marrero, we talked to their provost, and they were very, very gracious, said, you can have this space. So without having to build a big building, this is a really economical way to develop a medical school. $1.7 million, we did some renovations. We're gonna start with 40 students down there in July. Okay, we already have the third and fourth years figured out. So it's putting the first couple of years. Now, when we compressed our medical school, you remember Dr. Kilpatrick, you probably spent 2 years, that's what I did. Now it's 18 months. So again, you just go straight through to 18 months, but it makes the curriculum very exportable. So we're hiring some faculty there, getting some Georgia Southern faculty. We have a lot of physician faculty at St. Joe's Candler. So this is really an ideal situation for like a regional campus. And the students love this campus because there's, here we have kind of a food desert, if I can say that. There's not a lot of food options. With Georgia Southern, there's a Starbucks, a Chick-fil-A, and a Southern cafeteria that you can walk to. And there's parking and plenty of housing, and it's in Savannah. I mean, wish I could go to medical school again. Next slide. All right, so this is some other things we have to be aware of. So I think the medical schools here, we all collaborate. I think we do a pretty good job putting out medical students. But the trouble is we export them because we don't have enough residency slots. So this is a huge problem. This is a real big problem. So if you look at this slide, and this was from Shelley Nuss, our campus lead in Athens, who's become an expert on GME. And the state has done a lot in the border regions to try to increase the number of residents. But look where we rank. I hate when Georgia's always 41 and below. And that's where we are. We are 41 in 2010. We increased the number of GME slots, but the population grew, and we didn't really catch up and remain at 40. And so we export students to South Carolina, Florida, Alabama, everywhere. I mean, so that's a real problem. And the problem, GME is complicated. There's caps. So the federal government caps the number of positions we have. So Emory and us, who could really love to expand, we're capped at a certain number. So any residents we increase, the health system or somebody has to pick up. So there's some ideas we have, we could talk about later about what we could do with that. Florida has a program where they pay the hospitals a certain amount of money to have them increase the number of residents. But this is a problem. With the Great Committee, we increased the number of slots at Northeast Georgia. They've done a great job increasing slots up in that to the woods, up in Habersham. And Wellstar's increased the number of slots. And there's been some other small increases. But building a residency is complicated and expensive. And a lot of hospitals aren't ready to do it. It's really hard to develop a new anesthesiology residency, right? That takes a tremendous amount. So most of the new residencies that have been developed are family medicine, internal medicine. We need that, but we can't forget about all the other residencies. OBGYN has been proven difficult. Psychiatry, all the mental health fields, really, really difficult. So those are some of our problems. Next slide. So here's just to tell you about, we have a great GME program here. Natasha Savage is the leader. We call it a DIO, Designated Institutional Official. We have 51 ACGME approved programs. We have about 580 residents. Now, the good news is the federal government did allow through the Consolidated Appropriations Act of 2021 for you to apply for residencies above the cap. So we applied and we got 2.44 positions. It doesn't sound like a lot, but there's only 1,000 for the whole country per year. So if you figure there's 50 states, that's not many to go around. So at least we got something. So it's at least a step in the right direction. But we really have to do something more about that. So the state has to, besides you and me, has to consider GMA. We're going to produce a lot of medical students. They're going to do a residency up in the Northeast. They're going to marry somebody up here and they're going to listen forever. Yeah, it's happening.
And that's not Northeast Georgia anymore.
No, that's worse. That's New Jersey. Right. No, that's the problem. So the more we can keep in the state, the better. Next slide. I think that's just the questions. Hey, I want to thank you for all you've done for undergraduate medical education in GMA. And thank you for expanding the Medical College of Georgia. I think all the medical schools are grateful for what you did, but we got to tackle GMA. And we've got to tackle this problem we're getting. So even when we get these physicians out there, you've heard a lot of these places are physician deserts. It's hard to get doctors to stay there. So we gotta think of more creative ways of keeping doctors there. Because we don't want them to all leave after they do their commitment. Hopefully after their commitment, they'll start a family and they'll be happy there and they'll stay. So,
Yeah, back when you showed the map at the beginning of where all of your students are, I didn't see any around Columbus area.
yeah, go back to that slide. That's a good question. We actually have students in Columbus, but, you know, because Mercer and Morehouse developed campuses there, we kind of,
Right.
we kind of don't want to overcrowd it. But there is that one white dot, I think that's Muscogee County. I don't have the counties listed on here, but we do have some, Muskogee, excuse me, not from New Jersey, my accent's terrible. But we do have some students there. We do have some students there, but we try to, you know, since Mercer's got a campus there, we've decided to go down to more to Albany and Thomasville and Tipton, where, most of the competition in Thomasville is in Florida State, so they're, you know, even coming above the border. But Albany, PB Putty's been a great partner for us, so we've had students there. As you can see, when we're in these cities, we're all over, you know, we're all in those white dots, so we're all over in some of the smallest counties. So there's evidence to show that if you have a regional campus, students train at a regional campus, they're more likely to practice. And we have a lot of anecdotes, you know, regional campuses is only 10, 15 years old, so it takes a while to get data. But we have a lot of anecdotal data that it does work.
So about the federal cap, that's the ACC GME,
Yeah,
and that's not really a governmental agency, is it? Or is it kind of quasi-governmental?
ACGME is not a government agency. It's kind of like the LCME that credits residents. But the CMS, you know, funds most of the residency positions, either through Medicare or Medicaid. Georgia Medicaid funds quite a bit. And then, you know, we have some military people that train here, we get funding from them, but our cap, so we have a cap about 300, all right, that's about our cap. And the trouble with the cap is they froze.
That's for the state.
That's just for MCG.
Oh, just for.
Yeah, we're about 299, 300. And we were frozen at 1996 levels in the Balanced Budget Act. So our costs were low. So what we get from the federal government is low. Not only do we not get many positions, but the cost we get for position is pretty low. So if you're a newer program, let's say you're Northeast Georgia, you start a new program. We call that a virgin program. They never had residents before. They have 5 years to run up their numbers to get a new cap. So then they'll get a cap at 5 years, but after 5 years, then it's frozen. So, you know, population, of course, moved south, but the GME positions didn't move with them. And so it's going to be very, very difficult to get the federal government to change that. And there's been a lot of movement. You know, Medicare funds GME. Should they fund it? You know, why doesn't the private insurance company fund GME? You could ask. There's a lot of things you could ask, but it's all Medicare and Medicaid that funds it. So that's been, you know, there's been a lot of think tanks that have looked at GME. Is this the best way to fund it? And most of them say Medicare is not the best way, but they don't have a solution. So it's a problem without a national solution. But the states could potentially kick in and help. So the state of Georgia could do something like the state of Florida does. In other words, we could look at some other models. California's done some things, Florida's done some things.
Florida, bring it to us, bring it to us.
All right, we'd be happy to bring it.
Yeah, Florida, you know.
Yeah, Florida's real close, and they've done a really good job. It said Florida roughly just pays, we look for shortages and they'll pay a hospital, say, $100,000 to train a resident. That's roughly what it costs to train a resident. When you look at salary, benefits, and then the educational support you need. So if you, I know it sounds like a lot of money, it is. Well, I like that. I thought you were like gonna go. Yeah, if you look at it long term, you know, look at the return on investment, but $100,000, you know, you could pay, I'm sure Stephen Milo would love it. You know, you pay anesthesiology or $100,000 in the hospital, and then you could hire more residents. Because right now, when we do something, we're over the cap. And so the health system has to continually pick it up. Or somebody has to.
And Florida's got a huge Medicare population.
Yes.
Is that, that's a factor in how their health financing is working, right?
Well, that's probably some of it. They also have a lot more cities with a lot more academic medical centers. So the other problem here is Georgia only has 2 academic medical centers. We got Emory and us. Those are really the only two academic medical centers where you can train specialized residents. If you look at a state with our population, Ohio, they have probably 5 or 6 the way you count them. I mean, they got Ohio State, they got Cincinnati, they got Case Western, they got Cleveland Clinic, they got Toledo. So they have a lot more positions and a lot more things that historically were funded. So here, again, it's a victim of circumstance. We're growing fast. And we don't have a lot of academic medical students.
And it's frozen in time. back in-
Yeah.
the
Yeah.
numbers are in the 1990s.
Yeah, you're exactly right. It goes back to 1997, and then, they throw out this consolidated act, but we got 2.44, and we're clapping, but that's a drop in the bucket, right?
So if you were to look at, I guess, obviously there's a shortage of healthcare professionals in rural Georgia, and really a shortage across the state. If you were to look at the formula from getting someone from high school to getting them here, let's just look at a position, coming up, a licensed physician. Where's the limiting reagent here? Where is the limiting reactant? Where is it? Is it the number of students that can be trained in Georgia? Is it the number of residencies? If we're just looking at positions right now, where would you see the most need to, open up more slots or pay the most attention to help grow the number of positions that we can train per year?
Yeah, well, pipeline programs are important. We have a pipeline program, CP goes back 3 years, that looks at disadvantaged populations, but there's a long way for that. So pipeline programs, you have to probably start in middle school, right? But the quickest way, the biggest bang for us would be GMA, because right now we're losing so many medical students that go out of the state for GMA opportunities. Right, so I think creating more GME programs is the fastest way. And that's what kind of Florida and other states learn, that you can get, if you have good GME programs, you bring people in and you save a lot of time. And so the Georgia Board for Healthcare Workforce has statistics, and they're roughly this. Marjorie Miller can correct me if I'm wrong. I think if you go to medical school here, your chance of staying in Georgia is about 30 to 35% long term. If you do your undergraduate and GME in Georgia, it goes up to about 70%. So that's what you got to do. You need more GME slots, and they have to be good GME slots, because our students, I'll tell you, we get great ingredients as to the other medical schools in Georgia. They can go anywhere. And don't forget, some of these people grew up in Georgia, went to UGA or Georgia Tech, and then they went to MCG. They just want a change. There's nothing wrong with that. But then we got to bring them back. And we got to think about how to bring them back.
So do we have enough residency programs, and do you think we have enough slots in medical schools to train the workforce?
I think we need more slots in medical school, but I think we've got to combine. We also have to have more GME slots, because if we just create more medical school slots, like we're behind in the nation, but we're worse probably. GME is just as bad, and so if you don't do them in tandem, in parallel, what you could do is just send more kids out of state. I think this Each Day Scholar program is going to help. And when that's finally mature, we want to have 30 to 50 students in there. That'll help. That'll start making a difference. But we need more than that. Definitely need more than that.
So 2 questions. One, what does limit, why is that program not able to start the first year? Why can students not enroll as each, say, scholars, their first year, right? So they graduate from UGA and they're applying to NCG. I'm seeing an answer behind you, but
No, that's a really good question. Well, we're smart enough picking them out, we will. We're trying to find out, we get the first year because we want to get them in medical school. And first of all, they have to know kind of what they want to get into. Because when they're coming to medical school, if they decide they want to do orthopedic surgery or neurosurgery, and they don't, then they have to exit. So we have off ramps and on ramps to get on. But we're not quite sure yet how to, we don't have a lot of people dropping out. So we thought it would be safest to wait the first year, go through an interview process, let them get used to medical school, really see what they wanted to do. Maybe in the future, we'll be smart enough, we'll be able to do that.
It incentivizes them to be in one of those specialties, but can I also follow up?
It's a little difficult when you are in medical school. You don't get into your clinical rotations until you're really a couple years in.
Yeah.
The first 2 years are mostly lectures, who has their own stuff. So you don't get a sense. And there's sort of a fork in the road that clinical students get in medical school. You're either a procedural, surgical, hands-on type person, or you're more of a thinker, cognitive person. I'm a hands-on person, but that part you figure out soon. Where that takes you, you don't figure out till later, but it's very hard to do the first 2 years because you're not really around patients, you're in the class.
As we open up to more specialties, you could take them in earlier, and so that's what we're working on, is trying to potentially open up to more specialties.
My second question, one of the proposals that we received earlier this morning, talked about students who don't match. And so I'm curious, how many students that are graduating from here are not matching? And then one of the proposals was to have, basically this kind of intermediate licensure where they could, practice for a year or so, until they match somewhere else.
Yeah,
How does that reach
it's a
to you?
really, really small number. It's usually a couple, 2 or 3, and usually they're often people that want, there's certain really competitive specialties, like Dr. Kirkpatrick, especially orthopedic surgery, dermatology. So sometimes the students don't want to do that, and so they'll do an extra year of research or something to prepare for it. So it's such a small number, I'm not sure it's worth having a program for it. But it's a good
But they
question.
have a license at that point, right? I mean,
Yeah, but
once you get your MD.
yeah, you have a license, but it's hard, you really can't practice without getting a license.
On other residents.
So generally what they do is a year of research or tuning up but it's a really small number. So,
Thank you. Thank you
All
very
right.
much for your testimony.
thank you, appreciate it.
All right, next we have Shannon Broxton.
I think it's actually Dean Crutler.
What is it? Oh, okay. It's just.
Go ahead. They switched.
So y'all are gonna switch?
Yes.
Okay. All right, John. Hey.
Good afternoon.
Good afternoon. It's nice to see all of you and thanks for coming to. Appreciate that. To start, jump in. Okay, can we go back to the first slide? Well, it's fine. I wanted to just, first of all, I wanted to start by saying the College of Allied Health Science was created about 55 years ago. And the purpose that we were created for was really to support the physicians and nurses here at Augusta University. And college was actually created really at that point by physicians to actually fill all the health professional programs or skills that they did not have or could not do as being a physician. Next slide, please. And so we're 55 years old this year, and we are made of 7 undergraduate programs right now. And we are going to have 7 graduate programs soon because we have a new program on the way that I will tell you about. So we are a college that absolutely supports the work of our great colleagues in nursing and our great colleagues in medical school. For example, one of our undergraduate programs, clinical laboratory science, nurses and physicians with the work that they're doing, they can't do the lab work. You can't take the specimen, they can't draw the specimens and then take them to the lab and then analyze them for glucose, analyze them for cholesterol. Dental hygiene is another one of our professions. Thank God, I don't know about you guys, but for my dentist, I've had the same dentist for about 15 years. Maybe he spent an hour in my mouth. Okay. But dental hygienists have spent hours and hours. Very important to have dental hygiene. Health Information Administration, a program that is struggling for us right now. But it is absolutely the kind of information that health information needs to be able to tie clinical information with coding and all of the ramifications around insurance and payment. Very important for health information. Health Services is the new undergraduate program that we have right now. Has 283 students in it actually, so it's one of our biggest programs right now. Nuclear Medicine Technology is another program. If you've ever had a gastric emptying study, or a cardiovascular stress test, you would have worked with a nuclear medicine technologist. Radiation therapy is another undergraduate program, which of course is a program who is going to administer the radiation to patients when someone has cancer. Certainly the nurse is not going to administer that radiation, the physician is not going to do that. Radiation therapist is going to do that. And then, of course, we all found out how important keeping an airway open during COVID is. And those are my respiratory therapy professionals that we must have in the ICUs and in the emergency rooms. The next slide, please. My graduate programs, we're very proud of our medical illustration program. I'll have to show you a few slides on that later, but our nutrition program. And then we kind of have our three very highly sought after graduate programs, which is occupation therapy, physician assistant, and physical therapy. Then we have a graduate program actually in clinical laboratory science. And the program that we have coming in fall 2025 is speech and language pathology. So we hope to have our first cohort of students. We actually will be starting to accept those students by fall of next year to enter in the following fall of their first year. So y'all, next slide, and actually we can go to the next slide. Okay, thank you. So this is probably the most important slide that I have up here for you all to see. And actually, this is the number of job openings and job postings for allied health professions in Georgia and South Carolina. The projected annual openings, and then in the last 12 months, the number of postings you see there for allied health jobs. And as you can see, that allied health jobs are going to be needed in Georgia and in South Carolina. And this is just for these four, annually coming up. But you can see how hard these jobs are to fill from the number of postings but compared to the number of openings that are. So they are very hard to fill right now. We have students who, of course, are all over Georgia, who are in every county of Georgia in all of our professions. So what I wanted you all to see about this slide is how important it is to have these health professional programs and what we are doing for Georgia and South Carolina. Now, if you go back to the previous slide, and so these are our graduates over the last 5 years. So you can see the numbers of graduates, and we aren't talking huge numbers of graduates, but the number of openings that they have. And that's one thing that I think will be important for y'all to understand, just like Dr. Hess is talking about the complications of accreditation and federal regulation over his program. I have the same complications with finding clinicals for my students. We have same complications with accreditation for our program. All of our programs also have internships that are associated with them, where those students are out in hospitals learning how to apply their profession. And they are always a limiting factor that we have in getting students into those positions in hospitals. So, and certainly as I continue to talk, I want to, show you maybe some areas that I think that we could probably grow in, but I also want to talk a little bit about the limiting factors that we have to grow. So you can go to the next slide. All right, clinical laboratory science. What I wanted to bring, so these are actually, we call these slicks. I thought it would be good for you guys to see what we take out with us to recruit students. And you will see for our bachelor's program in clinical laboratory science, we only get about 39 applicants a year for that program. Our cohort is about 28 students, and you'll see at the bottom of the slide, you'll see the average pay and what we think will be the job market growth from the Bureau of Labor Statistics for growth in positions in clinical laboratory science. There is a central theme for undergraduate programs that I want you to see, and if you would forgive me, but those programs are not the sexy programs that I have in graduate school that have bigger salaries that people really are gravitating to. All right. So these needed professions are not, because honestly, they are really hard. It's hard science. Clinical laboratory science is hard science. And so we need people who are interested in that. So applicant numbers are small, and we are recruiting all over Georgia. We have a very expensive digital campaign where we're recruiting it, trying to get students to come into these health professions, and you can see how much they are needed all over Georgia. Next slide, please. our master's degree program. So clinical laboratory science is a program where we have a bachelor's degree as well as a master's degree. We also have a distance cohort of these students in Lawrenceville, Georgia as well. So we are training students in 2 sites for our clinical laboratory science program. You'll see 19 applicants for our master's degree program. And what we developed the master's degree program, we developed it because there were lots of biology majors who had no place to go. There were chemistry majors who had no place to go. So we developed a master's degree, and we have been able to get some recruitment in those programs. Next slide. Yes, you have questions?
I'm just remarking on how low that pay is.
Not, and that's one of the issues. Hard
You don't
science,
get a master's, you get paid that.
you're gonna get paid the same as the people who get a bachelor's degree, because there's no differentiation. Next slide, please. Dental hygiene, about 61 applicants last year. We had 56 total enrollment, and you can see dental hygiene pays a little bit better than being on a laboratory science, but they're needed. 18% growth, market growth, very much needed. Next slide. Health information administration, market growth is 15, 27 total enrollment right now, 30 applicants. Again, one of the issues with health informatics is that it's still relatively hard science. People have to have anatomy and physiology. They have to have anatomy and physiology with the lab. They have to have accounting for it. They have to have a computer course for it. And so people are not gravitating to that as they used to. And so the numbers are speaking to that right now. Next slide. Nuclear medicine technology is also a program that is struggling a bit. I apologize, I don't have all the data for that program on that slide yet. But
Where's the other program? You said the 2 of them in Georgia.
there is enough, we have a distance program for that one also in Lawrenceville, Georgia. So there are 2 cohorts for those students. So we're training students in Lawrenceville and in Augusta.
So the 2 that you have here are both run by Augusta University.
Both are run by Augusta University. So for our clinical laboratory science program as well, it is the campus faculty that are taking care of those programs. Yeah. Next slide. Radiation therapy, total enrollment is 19 right now. We typically have about 32 applicants. 32 applicants for that program, fairly robust for us for that program, again, not sought after. And it is one of those programs where the accreditor has very strict requirements. For example, if they go to a radiation therapy clinic, if that clinic has 2 beam accelerators, I can only have 2 students there. Okay, if they have 3 beam accelerators, then I can have 2 students there. So many of our programs have that kind of restrictions put on them by accreditation. Next slide. Respiratory therapy, again, found out how important that was during COVID. 42 enrolled right now, not a robust applicant number. You know, if you all have any ideas how I can increase those applicant numbers, I'm more than willing to listen to you. But certainly we are still rolling out professionals. And actually, since COVID, our respiratory therapy program has had a huge impact. And so we are doing much better than that, rolling out applicants, and you can see the salary for those folks there as well. So not high dollar salaries in any of these undergraduate programs, but absolutely needed. Next slide, please. Health services is a new program. Health services is a program where all of our undergraduate programs, students typically are spending 2 years getting their prerequisites and their core completed. At the end of that 2 years, they've applied to our undergraduate programs, and then they come into clinical laboratory science or respiratory therapy or or nuclear medicine. For the students who don't make it into those other health professional programs, the BSHS becomes a place for those students to bleed to. It's a word that we like to use. So they will have a degree in health services. There are bachelor's jobs available for them in health services, so they are getting jobs as well. But they are not traditional health professional degrees. So they are not traditional health professionals that we're giving in that program, but it is for all of our future health professionals in in the undergraduate programs are, all right? And there are 283 of them enrolled right now in that program. So we have a lot of students who are actually planning to either come to the health professional side or they will get that.
So these are students who like don't get into nursing school, is that what you're saying?
Never,
These are just students who haven't decided what kind
no,
of.
nursing has a whole other cohort. I don't know what degree program they're actually in, but they have a whole nother cohort where the students who are pre-nursing are in. These really are students who have no interest in nursing.
Mhm.
Right. They
Right.
are, right. Okay, next slide. Occupational therapy, again, one of our highly sought after graduate programs. There is more competition in the state. Augusta, Georgia State has just opened up a new program, and so it has caused a bit of a dip in our enrollment, but our enrollment remains strong and our students remain strong in the occupational therapy program. Next slide. Physical therapy, applicants remain very, very strong in physical therapy. Salaries in physical therapy are quite high. And even though I am sorry that it is not up there either, but they remain quite high.
That's what that handshake means.
If you do that, you've done it, right? So thank you for that. Next slide is our PA, and you can see PA salaries are fairly robust. Job growth is going to be great. Typically, we're having 300 to 400 applicants for our PA program. So PA program is a very highly sought after program here at Augusta. Next slide. I wanted to just throw this in here just to make sure you know that speech and language is coming. Speech and language, there is a huge shortage of speech and language pathologists all over Georgia, and we want to be able to help do our part. Right now, that there are only 250 seats in Georgia for speech and language pathology. Education, we're going to be adding about 44 more seats to that cohort, and so we hope to be turning speech and language therapists out by our first plan, not by 2027. Is what we are hoping for. So we feel this is going to be a very important program, and I actually think it will also be a very highly sought after program. Next slide. We're very proud of our medical illustration program. There are only 4 in the country, 4 accredited programs that are in the country. It is a program that competes against Johns Hopkins, who also has the nearest program to us. And I'm very proud of the work that we have. Typically has around 9 students, as you can imagine, very intense interactions from faculty with students. So the enrollment on that probably won't be growing much unless we can do a lot more back.
So there are only 4 accredited programs like this in the country?
In the country and 1 in Canada. Yeah, next slide. And as part of that, we've got a robust training in our medical illustration and anaphysology. And in anaphysology, you can see the gentleman up here who has an eye missing. There is an artist in our program, Amanda Bear, who is able to do this kind of work where she designs eyes, synthetic eyes, and then you look at the gentleman at the bottom of his glasses and his new eye, or even look at him right here, and you can barely tell that he has a prosthetic eye. Yeah, so. Next slide, please. And that's it. And the only last thing I want to say, if we talk about limiting factors for my program, I'm sorry, I don't have a plot on this. Space is always an issue. And you saw that there were about 730 or so annual openings for PAs every year. I mean, I am pretty much done with about 48 that I can admit every year. I mean, I would love to double that number and but I can't do it in my current state. So space is always a limiting factor. Faculty also is a big limiting factor. A lot of times my faculty would make more money when they're in a clinical position, especially for PA and PT and OT. And it's very hard to convince those people to come over to this side of the coin. Clinical sites are always an issue for us. Sometimes, many times, we are competing with physicians for clinical sites. PA competes for positions. So those become limiting factors for us. As you all saw from my undergraduate program, applicant numbers can be a problem. You know, we're reaching the people, even though I have a very robust digital campaign that we are recruiting all over the state, it becomes really difficult to reach the population. And then, hey, your reports is always an issue. So,
I have a couple questions.
okay,
I may have missed it, but the health services program, that seems incredibly important, because when we were hiring people in my office, we're hiring people off the street who just finished high school and haven't had a lot of training, they're training on the job, so I think it's really valuable what you're doing. What are the prerequisites for that?
so the health services is our only open degree program. So for the other 13 programs, there is an admissions requirement for all of our programs, and they are selected. Our health service program is not selected. Students can declare that program when they come in. And that's why it has 280. One of the big things.
Just one follow-up this year. I'm curious about, we throw a lot of money at the technical college system with regards to workforce, especially healthcare workforce. I'm just wondering if you're interacting with them in any way with the technical college system.
At one time, I had more interaction with the technical hall. I had much more robust recruiting with that, with some of the 2-year schools. Is that what you're talking about, Senator? With some of you, I had much more, but many of those schools were, you know, combined with, for example, consolidated with other schools. And so when that happened for some of my undergraduate programs, I no longer recruit. We no longer recruit at some of the places that we used to recruit. All right, that we used to have a very strong recruiting relationship with.
Just seems like there'd be some value added there.
Well, there was that when I could feel comfortable about recruiting. I mean, well, I'm not recruiting as I should at 2-year school. Let's say that. Okay.
Okay.
Because the
We can
cohort,
jump to that.
the ones that I were recruiting with are gone now. They're gone now. All right, so.
Right, but we've still got a lot of technical colleges who are doing programs that seem like they interact with one another.
If there's anything that we can do to help us during that distance travel, we can bridge that gap again.
Well, maybe there is something that I have not looked at those 2-year technical schools. That could be quite possible.
Thank you very much.
Okay.
All right. Now,
I mean, you can't tell me I'm gonna close and then put me in the middle of.
you are the close. You are the close.
I gotta fix it before I hold it on. You know, I've been wanting something like that. First thing for you, your intercede provider for our little OCD. It's been on your mind too, for a couple hours. Okay, thank you for having me. Thank you, Chairman Hatchett. Thank you for the rest of your attention. We started the day together. I'm excited we're ending the day together. When you go to concerts, you have opening acts. And then so I was been planning all day that I was going to close her. I was quite intimidated, but then thought that having the opportunity to not close would be good. And then when I had it, I was like, no. Let's let Dean Brentler go. You know, they've shared a lot, everybody shared a lot of information today. So pardon me for any redundancy. You don't exactly know what you're going to get with everyone's presentation, but maybe the more times you hear it, the more times it'll stick. So I'm Shannon Broxton. I'm a nurse anesthetist by trade. I am born and raised here in Augusta and spent the last over 23 years being a nurse. In the last 13 years of that, I've been a nurse anesthetist. In the last 10 years of that, I've been an instructor in the nursing anesthesia program, now up to associate professor. And since 2018, I've been the program director. So I have the privilege of sharing a couple of things with you guys about our college in general. There's just a few slides here just to discuss, you know, our mission, our vision, and how we see ourselves fitting into the crises we're seeing across the state. So These are our mission and vision, and essentially what it says is that our goal is to provide quality healthcare professionals in the nursing field across all domains, from the entry-level nurse, BSN prepared, all the way up to the doctoral prepared nurse. So, like the others that came before me who are leaders in the colleges who reported about accreditation, we certainly have those same situations here. We are under the governance of the Georgia Board of Nursing. We are SACS accredited, we are CCNE accredited, and we are accredited under a special accreditation body that specifically only accredits CRNA training. Okay. So this is a little bit of a busy slide. We have 3 departments in the College of Nursing, and one of them is the Department of Pre-Licensure Programs. And under that, we have an accelerated BSN program, we have a traditional BSN program, and we have what we call the clinical nurse leader, which is an MSN. It's still an entry level into nursing, because these are for folks kind of like you alluded to with me, Pretlo, who said, you know, I really want a degree in sociology or maybe even respiratory therapy. There are a lot of respiratory therapists that have a career and then they interact with nurses and then they make the decision that they want to go into nursing school. So that's our pre-licensure program department, I'm sorry. And then we have a department of D&P programs, and there are 7 programs in there. This is where APRNs are. It's called D&P, and I want to kind of explain to you what that is. There's different types of doctoral preparation that you can get, you know, across disciplines. In nursing, you have a choice of a D&P or a PhD. So everybody's familiar with what a PhD is. The D&P is specific to a clinical doctorate. So these folks have to go in and do their typical extent of their clinical training and their didactic preparation while completing their doctoral project and doctoral preparation. Of multiple classes that they have to take for that. And what that helps them do is do deep dives into systems at the micro, macro, and meso level, and looking at problems in healthcare, being a part of that solution. Like the way that I like to explain to my students is you have wonderful PhD researchers that go out there that are creating new clinical knowledge, and the D&P provider is a bridge that closes the gap between clinical findings and research and actual clinical practice. So then in our Department of Nursing, we have our Doctor of Philosophy in Nursing. All right, next slide. So we are known as Georgia's flagship nursing school. Back in 1923, we were the first state, Georgia State nationally accredited baccalaureate nursing program, and that was actually in the UGA campus, Go Dogs. And then later on, it actually became tucked under MCG. Here on this campus, it became part of one of their programs. And then many years later, we went through some name changes, and now we are Augusta University. We've graduated nearly 20,000 nurses in the 80 years that we've been doing this kind of business. And we produce about 400 graduates annually just in our BSN and MSN programs. And then we have probably closer to 110 doctoral degrees, maybe even more than that, maybe closer to 115 doctoral degrees. So looking ahead, what are things that the College of Nursing can offer, or growth potentials that we have? One is for the growth potential in Athens. We just completed a really nice remodel of our satellite campus in Athens, as MCG kind of highlighted, where they have a nice little infographic to show wherever they were in the state. What I can say is that we have one satellite campus from the College of Nursing that is in Athens, and we do pre-licensure nursing training there and some of the other types of B&P training that we do. We do have growth potential in Athens. We recruit a lot of nurses from Athens, and they want to be in that same area, close to UGA. The other thing is just to increase enrollment initiatives across programs. It's been a goal of President Keel's to increase enrollment by 2030, and we've been moving in that direction. All the programs have seen growth, some of them exponentially over the last several years, but we suffer the same kind of issues that others in healthcare suffer as far as funding for faculty and clinical sites. You know, and if you think about it, it's a little bit of a trickle down effect. If you have a shortage in nurses, you have a shortage in nurses that can train nurses. So it's a pretty bad negative feedback loop. One of the things that we're looking at moving forward would be the addition of the B&P nurse midwifery program. It's going to take a little bit of effort to get that all off the ground, but we know that Georgia Georgia's in dire need of increased access to healthcare, especially in that population. And then we're exploring options for an online master of quality and safety. Yes. So a little bit more about that nurse midwifery program. There's over 70 counties in Georgia where there's no OBGYN providers. And there's a statewide crisis. We know that we are very, very low. Well, let's say this way, unfortunately, we're very, very high in the numbers of infant and maternal morbidity and mortality. So this program is going to go and live under the DNP program in the Department of DNP programs. And just like the CRNA program, they carry their own special accreditation, which is what we got.
Tell us again what DNP.
Doctorate of Nursing Practice.
Of nursing practice.
Yes, next. Some of the other things, this is kind of a wrap-up slide that I wanted to share. These are just some pictures of nurses in action and training. One of the things that I wanted to share is I kind of alluded to some of the challenges we have as a college. One is faculty. You're kind of told when you come into academia that your salaries are not going to be commensurate with what you make in clinical practice. The clinical practice salaries are escalating at a rate that USG has not been able to keep up with. So we can't recruit enough faculty to train more nurses. So one of the questions you might have is, how do we train more nurses? We need more faculty. If we get more faculty and when we get a better budget and we get better resource alignment, we can hire more faculty, we can retain the faculty that we have, which is super important, because we'd rather invest in the good people that we know instead of trying to find additional people. Right now, we have about 55 full-time faculty, and that's across all programs, and that's considered with the consideration of that being somewhere between 900 and 1,000 students. We have equal to that, maybe even a little bit more part-time faculty. But it's nice to have the full-time faculty, to have that engagement, to have that commitment. And we've had, we have better outcomes when we're able to use the full-time faculty that we have. All right. So now I'm gonna put my hat on. All right. So my job today is, in my capacity, is to talk specifically to you about how we train CRNAs here at Augusta University. And the good news is that trickles right over to Emory University. We have a faculty member here from Emory University as well. So next slide. I do have a disclosure statement. I am a member of Georgia Association of Nurse Anesthetists. I'm also the president of the organization. But today, I'm Shannon Broxton, program director. Okay. So here's history. This is a picture of my grandmother giving anesthesia back to I bet you guys didn't know how old CRNAs are as far as a profession. Very, very old. Okay, well over 100 years.
Wow.
In fact, the first persons to administer anesthesia were nurses. It's kind of the model that, it's the model that everything else was kind of built on. The one that people talk about the most is Alice McGaw, who was known as the mother of anesthesia. And she began with the title of nurse anesthetist for Dr. Mayo back in 1893. Open drop ether. If anybody in here has experience with open drop ether, you have my respect, because that was a long time ago. Not you. Next slide. So a little bit about CRNA statistics in the United States. There are over 130 accredited CRNA programs. We're working to get up to probably 155 because programs are popping up all over the place. Why? Supply and demand. So, there's a need. So the COA, which is our accrediting body, has decided that, if you can show the need, then we're going to grant you the access to train more CRNAs.
So the gray states don't have.
The gray states don't have CRNA programs. There's nearly 3,000 new board certifications annually. So that's about how many in the country new CRNAs we're producing annually. And there's over 61,000 CRNAs practicing in the US right now. Here in Georgia, as far as contributing to the workload for us, we have 2 accredited CRNA programs. That's Augusta University and Emory University. The number of graduates annually, AU up to 40. And the reason I say up to 40 is as recent as 2018, we had 20 students per cohort. We accelerated that up to 10 students, by 10 to 30 students. And 2 years ago, we were approved to go up to 40. If you want to know about constraints on our program growth, it's specifically the same things I named earlier: access to clinical sites and faculty. We have no short supply of nurses, highly trained, highly qualified nurses in line with these CRNAs. We just don't have the capacity to train them because of faculty and clinical sites.
Money.
That's what I said. We need, we're a state funded school. So we are at the mercy of what funding USG has and how that funding is allocated specifically to Augusta University, and then how that budget at Augusta University trickles down to the College of Nursing. There are over 1,600 practicing CRNAs here in Georgia. One of the things that I'll say is, and we don't have to go back to the previous slide, but I'll mention that one of the testimonies earlier said that there are 14,000 openings, maybe more, for nurses in Georgia, and we're able at Augusta University to graduate about 400 a year. So when you think about the great retirement and you think about people job shifting, with the CRNAs, we're kind of in the same boat. I mean, we're all there, all the healthcare providers, where you're in the age of the Great Depression. Well, not the Great Depression, it is depression, but the age of great retirement. And we can't keep up with what we're losing. So, Augusta University is trying to do their due diligence to increase enrollment, and I have a personal strategic plan that can advance us by another 10 slots hopefully in the next 2 years. And, we can get that graduate number up a little bit more to help combat that problem. So some good news regarding the council accreditation. I don't mind sharing this. We recently got news just last week that our program has been reaccredited for the maximum 10-year accreditation. So we're very, very happy about that. So for the next 10 years, we're good to go. We're going to keep pumping out high quality ceremonies. You'll look in the pictures here, and some of us look the same as we did before. Some of us don't. This is our faculty. Many of them are in the room. I have 3 part-time faculty, and I have, including myself, 5 full-time faculty. And then I have in the lower left corner, if you're looking at the slide, is our program manager, Nicole, and she's been helping us a lot today. So thank you. Thank you all for being here and helping out for this morning. So I'm going to finish out here with the next few slides, just talking specifically about the program, what we do, what we contribute, and how we train CRNAs. So we're the first CRNA program in Georgia, started about 1995. We are the longest running program. We've been doors open since 95 for different periods of time throughout. Since 1995, we were the only program. We now share that title of CRNA program in Georgia with Emory. But we have produced nearly 500 CRNAs since we opened the doors. And the number seems a little low if you did a little bit of math and you're like, the math isn't math, and if you put out 30 to 40 CRNAs, that's not right. When we first started, we started small. So for the first several years, it was maybe 5 CRNAs, and it grew very quickly. When I graduated from this program in 2009, I graduated a class of 15. And now I'm the director of a class of each cohort of 40. So we have been trying to answer and grow. Good news, 90% of my applicants are from Georgia. 90% of them come here and stay in Georgia. So that's really good news. I can't help it that they come here from out of state because we attract good candidates and decide they want to go back. But I think 90% staying in Georgia is a pretty good number. Up to 30% are working in rural communities, and I can attribute some of that to the fact that we require them to rotate through rural communities. They go through, let's see, Dodge, Habersham, Taylor, Tifton. There's a map over here that one of my colleagues put together, and each one of those pins, each one of those sites are listed that we go to in Georgia, with the exception of 3 out-of-state sites that we expanded to so that we could grow the program. But the majority of them are in Georgia, and you can see where the push pins are right there that kind of identify exactly where we are across the state, and the answer is everywhere. Okay. So our admission criteria, like I wish I had what Dr. Pretley called, Dean Pretley called a slick. I need a slick so I can show you. We're gonna get slicks. But our admission criteria is pretty lofty because we have nearly 300 applicants for those 40 spots every year. There's no short supply of people who want to be CRNAs. I could reasonably, based on what the criteria are that we're looking for, I could reasonably probably accept 100 of them, but I can't train them. I can teach them, kind of like Dean has said. I can teach all the all the medical students you want. I just can't train them anywhere. That's the same kind of situation. So our admissions criteria are that you have a BSN or an MSN in nursing. It's unencumbered. You don't have any restricted RN license. Your license in state, either through a compact license or through Georgia. You have at least 1 year of ICU experience. That's per accreditation. But I'm going to give you averages in a moment. You have a minimum of 3.0 overall GPA. You have CRNA shadowing experience, and you have professional academic records. That gets your application through the gate. Now, statistics on our most recent accepted class. Average ICU experience is 3 years. Average GPA for the last class was 3.89. Average experience was, shadowing experience was somewhere around 16 to 20 hours that they just spent on their own, just making sure they wanted to be CRNA. So these nurses that are coming into our program are the top, best of the best in the ICU. So as far as training requirements, some of these things are going to vary. Like my credit hours might not marry up with Emory's credit hours, but our requirements are the same. Ours are 113 credit hours over 36 months. Back in, probably about 10 years ago, the DOA decided that all CRNA programs by 2025 were going to be doctoral prepared. So the minimum that they would allow your program to be, the minimum length was 36 months. So we are a 36-month program. You get your holidays, your academic calendar, you get those holidays off. But other than that, it's 36 months, 113 credit hours. We give them, prior to going to clinical, 100+ hours of lab and simulation. And you guys have the benefit of seeing some of their dedicated lab spaces and the shared lab spaces that we share with MCG over at the ISC. They have over 2,000 hours of clinical training. Most of them, and this is the actual clinical training that they are not allowed to count sleep time and things like that. But I say over 2,000 because it's all over the map. But 2,000 is the minimum they're allowed to have to sit for the board certification. Minimum of 650 anesthetics. We average above 900. I think I had over 1,000 when I graduated. Not patting myself on the back. And then we have required specialty rotations. So whereas Dr. Myler, I think, spent a little bit of time talking about some fellowships that MCG has for specialty rotations, especially types of anesthesia. We have those embedded in our program. So they have a minimum number of open hearts they have to do, a minimum number of OB cases, regional anesthesia, acute pain, spinals, epidurals, lungs, neuro, pediatric cases, peds patients under 2, preemies, traumas. They have a minimum number of cases that the COA requires them to complete before they're board eligible. So in the didactic training, the cool thing is that anesthesia textbooks are multidisciplinary. The textbooks that we use to train our students are the same textbooks that are used in medical education in the physician side. We make them go through their foundational science courses, chemistry, they have a cadaver lab. We attend the same cadaver lab that MCG uses for our anatomy portion of A&P. They study physiology, pathophysiology, and pharmacology. And then we get into anesthesia specifics with types of anesthesia, procedures, equipment. We have our own simulation labs, and then we share those spaces over in the interdisciplinary center. And then again, I talked to you before, I shouldn't glaze over the doctoral project. The students behind me are probably saying you're not putting enough emphasis on the doctoral. They are, I say it. But there's a very big doctoral project coming of this, that they have to earn, to be able to say that they have the knowledge and the ability to go in and do an assessment of a situation or a learning or practice environment and make a clinical change. So some of the things about simulation, we started in simulation, and I want to talk a little bit more about that. When the accreditors came to review us back, what was it, February, one of the things that they really enjoyed about our program was how much simulation time that the students were getting. And when they went to visit our students in clinical, they were just really surprised about how ready and acclimated they were to be in the OR because of all these spaces that we've been able to offer them and the ability they have to train. These spaces that you guys toured right out here with our mid-fidelity ORs and our regional lab spaces, they have access to those 24 hours a day. The high fidelity OR that, you know, we took the walk-in tour to earlier, those are scheduled, but they still have approximately 1.5 hours each week in there, in addition to what they do over here. Simulation was brought to the university by nursing in 2008. And in 2000, and we opened an interdisciplinary sim center then, shared those experiences with other programs. And then we moved our equipment over to the ISC in 2018. So for the clinical requirements, there's, you know, kind of a two-step program here. For the first half of the program, for the 3 years, the students are in didactic and lab and sim, and a little bit of observation in the actual OR. Then we bless them and send them out to all over Georgia to do clinical rotations, and that's where they go to LaGrange for OB and to Putney for hearts and to CHOG for peds and all over for regional and to actually ECG for neuro. And when I worked for Dr. Myler about 10 years ago, before I came over here, I was the clinical director at MCG that ran the programs, SRNAs over there, and we were a neuro site, and that's primarily where I function. We have a lot of rural rotations all over Georgia. Can't name them all, but they're on that map, and I have a handout to give you guys that I'll make sure Bernita has. That's just a duplicate of that. And we actually have CRNA only practices. So there's areas throughout the state that are hospitals, rural facilities, but hospitals that are functioning in an independent model with just CRNAs. So there's that picture I was telling you about. That one doesn't have the pins in it. What I thought would be fun is you get your own pins and then you go through and identify exactly where all those are. But the nice thing is that we did put in parentheses the county that they're located in. So you can find your county in your region and kind of see where we are. And we are in Gwinnett for sure. We can look. So how do you get to be a CRNA after we train you? We've let you put your hands on all the things. We've taught you all the things that we can teach you in the book. You get to go to graduation and you have to sit for a very, very big test. Different than other disciplines and certainly one of the things that separates us from some of the other APRNs or different types of providers is we have to be certified. We must take a certification exam, pass it in order to practice. So all CRNAs, as in their CRNA title, are certified. Well, that's not enough. So you don't get to just be certified and go out and practice anesthesia. You actually have to be reaccredited, or not reaccredited, recertified. And that's an 8-year cycle where you have to come up and be trained by CEUs. That's kind of normal for nursing and medicine and everything. You have CEU education that you get. And then after you do a certain number of CEUs, at the end of that second 4-year cycle, you got to take the test again. So you are required by our certifying body to stay in the know on the knowledge that you have to have to be current in practicing our craft. So what are the things that we in particular in my program doing to try to tackle some of the problems we're having with rural healthcare? I don't really want to think of it as access to quality healthcare in rural places. It's really access to care everywhere. Just in the WellStar system alone, there's almost 50 CRNA openings just in the Atlanta area. So everybody's struggling. Everybody needs healthcare providers. So the more we can increase enrollment, as long as we're not reducing the quality, the better that we're going to be as far as being a healthy Georgia. And then recruiting highly qualified candidates from the rural and underserved areas, being mindful of that when we're accepting our class. What we do is we do try to target certain areas. We have partnerships with people in Columbus and in other areas. Columbus isn't really rural, but we have partners across the state that say, hey, this is a great CRNA candidate for you guys, highly qualified, and this person wants to come back and work for us. So we try to reciprocate those relationships. The other thing is probably since 2016, I've been the PI, principal investigator for HRSA funding. And we brought in for the nursing anesthesia traineeship grant, about $300,000. That money does not go to the program though, that money goes to the students. So that helps fund their travel. So we offer that to the students because when they travel to these locations all over the state, most of those places don't have housing. So they're working with everything within their own budgets to try to find places to stay. And we made a commitment for them to go to those places so they can see what practices look like in rural Georgia and maybe make a commitment to go there. And I think that's all I have to share. So thank you so much.
Thank you very much.
As you know, I was thinking about your money issue. And one of the questions that I have was, are you guys utilizing the preceptor tax credit program that we?
Oh, boy,
put a lot
yeah.
of money into?
We had not been in the past, and then we actually had somebody from Summit and up near Newman, Georgia, reach out to us as a preceptor that, and said, hey, there's an incentive for us to do this. Can you start tracking it? And then we decided to start tracking it. And it's a lot to track, but we have opened that up to all our preceptors across the state of Georgia to incentivize them to train.
Good move. And then still on the money piece, I noticed that there's a pretty robust foundation that goes with Augusta University Medical College.
Yeah.
Are you guys able to participate with those funds at all?
So they don't share much out of their bank account. We are married with separate accounts. Saw Sarah, I guess it's in her urban. Anybody from philanthropy that wants to help me out? We are working on that. All colleges, all deans, the university at large has an expectation to reach out to those people that we've been good stewards to and provided such good training and alumni connections with. We're constantly looking for gifts for endowed chairs and endowed professorships. And that's something that we could be better at that we'll work on.
And then just one more, when I was in medical school, I spent a lot of time not sleeping in a call room, but taking an emergency call
Yeah.
where that nothing good happens after midnight, right?
Absolutely.
So, but that's when a lot of learning takes place. So I'm just wondering if you guys have any kind of a call program set up.
Yes, we do. So one of our big players is in Macon. So when there was a Mercer program there for the CRNA training program associated with Mercer, when that program closed, we assumed that major clinical site at Madison. And we send 10 students at a time there, and they're on a call rotation. But even more so when we send students to one of our dedicated OB sites, which is in LaGrange, it's 7 on 7.
I have a quick question about the clinical sites. You said that you need more. What is what's stopping you guys from growing? Is it the lack of, willingness to participate? Or is it truly funds for y'all, or just a little bit of both?
It's multifactorial. So training sites used to be a hindrance. It's getting a little bit better now because there's a shortage. And now they see me as a really valuable friend because I can create a pipeline for them. So that is shifting a little bit. But when we go into sites that are also, as you saw with Dean Hessen's map, they're everywhere too. So if we're going into sites and there are other learners present, then we're competing with other learners. So having to do that across the state makes it kind of difficult. And there's got to be room for everybody. You got to have room to train residents. You got to have room to train the CRNAs. There's dental. The Dental College of Georgia sends learners over to our OR to learn how to do things and intubate. And the OMFS guys come over and do an anesthesia rotation. So there's a lot of learners, especially here at Augusta University, that we have to cater to and we should cater to. So, we can't do our dedicated training here in Augusta. There's not enough space. So we branch out just like the other places have branched out. But some of those places are small. I mean, you're talking about maybe half of the hospitals I have having less than 6 ORs. So, I can only send 1 or 2 students there and then actually get a reasonable amount. I'll give you a quick story. I was in, Cordial. I hate to call them out. I love Cordial. Great rotation. They ran approximately 1 to 2 ORs a day and had an OB suite. I was the only student there. I showed up 3 days in a row. The cases were canceled because the surgeon wanted to go home. So you gotta be careful, you know, I mean, it's a rural site, so sometimes they make the rules up and you know, I can't send multiple students there. So even though I have that many sites, the vast majority of them have 1 or 2 students. And that's what's allowing me to have my capacitance to be at 48.
That's what I was gonna ask, because I represent the 9 counties in Northeast Georgia.
Mhm.
I think it looks like you have one in Hall, that's it, my whole district.
Is that, Blairsville or Blairsville?
Yeah. So
Yeah, I'm in Gainesville. And I will tell you that we got a phone call from the chief anesthesiologist there about a month ago saying, hey, I can't recruit, I can't hire, I need help. And they were only allowing us to send 1 student at a time before. They said, you can send up to 4 or 5. And we're opening up all the specialties to you. We've got to have a pipeline to hire CRNAs. So we're making moves, but you know, it's nice. It's a great time to be a CRNA in Georgia. I mean, it's in high demand. It's a very, very profitable market for CRNAs right now. And if I could produce 100 a year, I still don't think that would be enough to kind of keep Georgia in the green forever and ever, but we're trying to do this.
In the model, what's typical? I mean, I had a vision or understanding that CRNA came in, but didn't reside there at that facility and report to work there every day, but is moving around on an as-need basis. Correct that. I'm sure that's a misimpression.
So what it's, if I'm understanding correctly, you're saying there might be a CRNA that's not dedicated to one of those hospitals that kind of travel between them. That's similar to what Senator Jackson was talking to with the testimony earlier about the hospital systems and locums. So what happens is if there's not enough volume, say there might be a surgery center or a hospital that can only afford to operate 1 or 2 days a week. So then a provider will go in and do cases on Monday, Tuesday, and some can go do Wednesday, Thursday, and tip in and do Friday, wherever.
And that provider is doing that as a solo act, as an individual that has relationships with these different institutions and is moving around. Wow.
Yeah,
So you're basically running your own business?
Yes, ma'am. That is, there are multiple businesses in the state of Georgia that are CRNA businesses that are either small or large.
And then the other model is institutions that are, I mean, I'm a part of Atlanta,
Yes,
you know, where Wellstar closed down 2 hospitals.
Yes, ma'am, I know.
You know,
We're just cousins. Think about getting stuck with the Wellstar case.
I was saying, praise, I'm in an area where, heretofore, there had been 2 level 1
Yes, ma'am.
trauma centers, but now there's 1. But in that area, you know, Emory Hospital, the model of a great big place like Emory, for example, are CRNAs there that are there every day, and but they come from the outside, or are they part of the structure of the
The workforce is gonna look different, but particularly in those larger institutions. Even here with Dr. Myler's team, he has his regular complement of full-time CRNAs or AAs.
right.
And then he has a staff of what we call PRN for as needed. And
Yes.
they'll call upon those folks to fill in the gaps.
So it's a combination of the 2. It depends on the size of the institution and the types of surgeries and procedures that.
Yeah, it's as much, most of it is about the need and the volume in the place. So, you know, there's a very high volume, exact hundreds of cases that they're doing, you know, a month over there. Whereas you only may do 100 cases in a year in some of your smaller hospitals. So, you know, that's where you have to be careful with that workforce piece where a small hospital might not be able to afford to employ someone full-time every day of the week. So they cut that out and they say, hey, I'm just gonna contract with you for 2 days. And I'm gonna pay that 2 day wage, because I can't afford to pay you for 5 days to be here. I'm gonna pay you a little bit more for those 2 days than what it would probably worth if you cut it into 5 pieces and I gave you 2 of them. But it's because I'm incentivizing you to make the drive and come down here so we can get some work done on those 2 days. And then I'm cutting you loose so you can go, fill in the gap somewhere else.
That's not. I understand. I know I didn't quite have my arm around me. Sure.
Thank you for closing us out. I know Dr. Russell King,
Yes.
you wanted to say,
Yes, sir. Mr. Chairman, Senator Worth, Senator Kirkpatrick, Senator Jackson, just on behalf of President Keel and our entire executive cabinet leadership, we thank you all for being on our campus today. We understand y'all are tackling some very serious problems that plague our state. And just as part of being Augusta University and the university system, we see ourselves being part of the solution for many of our partners. And we thank you for your support of the university and of the university system. Just to add to the question on our partners, the MCG Foundation and the Augusta University Foundation are very much in the trenches with us, helping us partner to bring the MCG 3+ program that you all heard about today, but also nursing scholarships to help serve this state. So we're very grateful for our private partners and our public partners, and thank you for your service to the state.
thank you.
It's been a great learning experience, speaking just personally, y'all have given us a great exposure to things that we now have a keener sense of than when you come and sit at our testimony up there and, go for the chat.
I'm gonna change my hair so you don't recognize me.
Oh.
Before we go, I just want to say thank you to members of the committee. Thank you to Augusta University. Renita, John, thank you once again for doing such a good job putting this all together. Thank you to everyone that testified today and showed up. We've got a big task in front of us. Obviously, this was an easy solution. There wouldn't be a study for it, but we'll say we're going to do the best we can, and hopefully some good stuff will come out of it. I think based on testimony at the last meeting, testimony today, we are. I mean, I know I'm learning a ton. I think we are. We'll be able to do something good. Talked to my dad on the way down here. He's a graduate of Medical College of Georgia, and I had to give a shout out to the class of 1989. You can tell him I did that. And,
Well, tell them that you did.
thank y'all very much for your time, and look forward to working with y'all. If y'all ever need anything, please reach out to me. Thanks.
Thank you.